All right, let me get it pulled up for y'all real quick so that y'all can see it too. Am I a co-host? I can share my.
Yes, you should be.
Oh, Lord. Okay, give me a second. Ash, do you have it on yours? It's not letting me pull it up on my.
Yeah, I'll go ahead and I'll share my screen with you all, and then I'll let you kind of lead us through it.
Thank
All right,
you.
can everyone see this? Okay.
Okay.
Great.
So Darius is a Black male in his mid-40s who comes to see you because he has been experiencing increased anxiety and feelings of wanting to jump out of his skin in the past several months. He presents to the session casually dressed, well-groomed, and appears oriented to person, place, time, and situation. However, you notice that he looks somewhat malnourished and very tired. As you conduct your intake interview with Darius, you learn that about a year ago, he moved back to his childhood home because his aunt passed away, and he is now the owner of her home as her only living heir. When you ask Darius about his previous residence, his answers are very vague, and it is clear that he is uncomfortable about that topic. Darius shares that his mother and father abandoned him at a young age, so his aunt chose to become his legal guardian and was his closest family member. He states that she did the best she could, but oftentimes they faced food insecurity and she barely made enough money to pay the rent. You learn that Darius had a rough childhood in which he often had to fend for himself and be the man of the house for himself and his aunt. As a result, he states that he is familiar with violence. When you ask him to explain the comment, Darius shares that his neighborhood was often a fighting ground between gangs and he regularly witnessed violent acts from a young age. He also remembers witnessing domestic abuse between his aunt and several of her partners and multiple incidents of drive-by shootings. During one of these drive-by shootings, a close friend of his was severely wounded and later passed away in the hospital. Darius shares that he got his revenge and since then has been in trouble with the law throughout his life. When you probe for more specifics, he states that he doesn't feel comfortable sharing that information and he doesn't feel that his past is part of his current problems. When you ask Darius more about his current problems, he shares that he often feels most anxious and uncomfortable when he is at home, and he tries to occupy his time by going to visit friends, looking for odd jobs around town, or visiting his church. You mentioned that he looks very tired, and he confirms that he often does not sleep well on account of the vivid nightmares he has. He explains he continues to have recurring dreams about old friends who passed away from various gang-related deaths, but when he wakes, it's hard to remember the details of what happened. Lately, Darius has had increased difficulty remembering important events and plans he has made with friends, and he states that none of it really matters anyways. When you ask Darius about his previous comment about wanting to jump out of his skin, he explains that he feels very anxious, as if someone might jump him if he walks around a corner, and this has impacted his ability to think straight. So our first question for Janelle is what protective factors did you notice with this client, as well as what risk factors did you notice?
So I'm so nervous that I'm under the spotlight and the only panelist on this call. But initially when I read this prior to, so I'd been provided this, and what kind of stuck out to me is one, that he had one positive relationship with a family member. He has access to housing. And another protective factor is that he is looking for jobs, accessing friendships that are hopefully, it doesn't clarify whether or not they're healthy friendships, but I just kind of made the assumption that they were. And then that he is engaged in some spiritual work as well with his local church. So I would identify all of those as potential strengths in helping him make the changes that he wants to make in his life. And then risk factors, he's back in the home environment where he experienced trauma, which is likely triggering him. He is also possibly in a bad neighborhood, and he doesn't have current stable employment, it seems. And then he has limited family networks.
Wonderful, thank you. So our next question for you, and maybe Dr. I, if you want to kind of jump in and provide your expertise as well, because I know you're
Yay.
experienced in this. So in your professional setting, how might you assist this client? And either one of you can start, that's okay.
Oh, so I, as I mentioned before, I work in private practice. And I am an EMDR certified therapist. So immediately I'm like, this guy needs to come in for EMDR therapy. That was like the first thought. So I'll talk about this today and what that would look like to begin EMDR with this client. My first step would be to do the assessments, the dissociative experiences scale, the PTSD scale, the PCL-5. The ACEs, which kind of already can gather what his ACEs score might be, right? And then I always traditionally just do the GAD, the PHQ-9, begin that history taking, really understand this client, look at what coping skills he's already using, and then begin working on being able to regulate his emotions and kind of see where he's at there. Those would be my first steps. Then we would identify his targets. I usually either do a trauma timeline or a top 10 list. And we get started working on EMDR if he's able to stay within the window of tolerance where he can become desensitized to some of these traumatic events that he's experienced.
Yes, thank you, Janelle. And so I'll share a little bit about just some of my experience working with individuals that have trauma. I'm not trained in EMDR, and so I'm so glad that Janelle is here to share about that. I'm trained in trauma-focused CBT and cognitive behavioral therapy approaches, and then sometimes I'll integrate, different theoretical approaches like narrative therapy. But working in an integrated behavioral healthcare setting, particularly like working with like youth and adolescents, for example, with like the Nueces Center for Mental Health and Intellectual Disabilities, I do contract work with them. And so we have an integrated care team, and we'll have a client assigned to a case manager, as well as a counselor, a psychiatrist. Depending on the level of care, they'll have different team members, and they'll even be linked to a family partner, which is support that is provided to the parents oftentimes, where the family partner has training and experience as well in providing support to parents, and they also have had a child themselves who has mental health needs and was receiving services as well, so they kind of know the role of the parent. So the whole family is sort of wrapped around in services. And specifically in my role as a counselor, I would probably do trauma-focused CBT with individuals that have experienced trauma. And there are some resources about TFCBT actually posted for Module 5 that you can see on our TexCHIP website. And there's some examples of curriculums that we would use. But with like trauma-focused CBT, we follow kind of like a practice acronym where we begin with the letter P, which is psychoeducation. And we kind of do this to help kind of normalize them to understand that, people experience trauma and that they're not alone in the trauma that they've experienced. And we might even go over some statistics about how often this occurs and what are some of the common symptoms and responses to various traumas. And then you have the R, which stands for relaxation. And the reason is for that, you don't really want to jump in so much right away into their trauma story and the things that they've experienced, because they may lack the coping skills to deal effectively with triggers, with reminders. And if they're going to go and they're going to tell you their story from the beginning of all the things that they went through, when they go home, they may have all this kind of ruminating in their mind. They might have suddenly all these intrusive thoughts that they're not prepared to cope with. And then that could lead to a crisis situation. That could lead to self-harm. It could lead to maladaptive coping. So you want to build them up to be able to kind of prepare themselves to deal with trauma. And so then you have A, which is affective modulation. This is where you kind of teach them about like how their emotions how they may experience different kinds of emotions and how to identify those emotions, how to communicate those feelings. And all these are like several sessions. And once you feel like the client is comfortable going through each of these modules, then you can move on. But then after A, you have C, which is cognitive coping. That's where you teach them about some of the cognitive strategies to help them deal effectively with, triggers and trauma reminders, or also just being aware of their own thinking. We teach them the cognitive model here, where we help them understand how our thoughts, feelings, and actions are all related, and that unpleasant emotions often stems from unhelpful thoughts, especially when it comes to trauma-related thoughts like trauma reminders. And sometimes people can, really have a hard time wrestling with unhelpful negative thinking or flashbacks, imagery. And then once you've helped them, learn some coping skills to regulate their emotions, you help them learn some strategies to manage unhelpful thinking, then you can go into the trauma narrative, which is where you help them start to tell their story about what happened. And, you may help them in a sense where they eventually get to a point where telling their story is sort of like telling an ordinary story, an ordinary memory. It's not, of course, ordinary at all, but their response to it won't be like as triggering or as unpleasant. And they will eventually get to a place where they can talk about what happened. They can share what happened to a point where they're not debilitated by their trauma narrative. And they'll find times in the story where they can reframe certain things, so maybe they may fall into some thinking traps like it was my fault, or I shouldn't have let this happen to me. Whereas those are opportunities to help kind of reframe that trauma narrative, because that's an unhelpful thought and it's an untrue thought. So we would kind of work through that to slowly build them into this means in which they can cope and strengthen themselves and deal with those unhelpful thoughts. But and then link them to resources. And then as well as in an integrated care setting, they're working with the case manager who's linking them to resources, linking their family to resources. They're meeting regularly with their psychiatrist to see if any medication can be helpful in managing any symptoms. And so it's a holistic approach that we would take. And so I know I'm saying a lot already, but I hope that was helpful.
Yeah, that's great. I think that's a really practical and useful kind of walkthrough briefly of what TFCBT is. So that's really helpful. I did want to kind of follow up. So Norina asked a great question about what is a trauma timeline. And Janelle, you also mentioned ACEs. So if you could just give very brief explanations of what those are and how you might use that information.
Yes, so the ACEs is the Adverse Childhood Experiences Scale, and it really informs us as to what sort of traumatic events that an individual might have experienced while growing up. So it's an informative tool. It also is something that has been linked to health issues. So I would utilize that to just see what their score is and to be able to ask more questions and get more information as we build the trauma timeline. Or top 10 list, either one. I typically more often do the top 10 list than I do a trauma timeline. But to talk a little bit about the trauma timeline and some of the key steps and what to analyze, that was Norina's questions, right? So key steps, like Dr. Icahn said, you want to make sure that the client is able to emotionally regulate before we're going to visit that trauma. There are some specific tools in EMDR, such as Lightstream, Container, and Safe Calm Place, as well as intuition integration. And those are all grounding mindfulness work to be able to get the client to understand, or not understand, but really practice and wire the brain in a way that when they're activated, that they have the ability to become, emotionally regulate, essentially, is what can happen with those tools. So that usually, depending on the client, can take a couple of sessions. Once they are able to emotionally regulate, then we'll go into their trauma timeline and or their top 10 list. And what that is almost exactly what it sounds like. Let's talk about what you want to work on. From an EMDR perspective, however, we don't need all of the information. We just need the headlines. So I want to know kind of how old were you, or when about did this happen? What do you want to name it? So let's call it something. So car accident. I don't want you to relive everything with me right now. I just want to know what it was. And on a scale of 0 to 10, we want to get the subjective unit of disturbance. How disturbing is this event when you think about it now? And we're going to go 0 to 10. And so after formulating that, and sometimes we do top 10, right? So we formulate that, that allows us to do what we call target sequencing. So there may be some that are themes. So there's like this overarching theme of failure, right? Like these 3 events. There might be one of I'm in danger because of an assault history, right? Or I'm dirty if there's sexual assault that's gone on. So we would kind of categorize those in themes. And then we would start with working with the client. Where do they want to start? And then also from my clinical perspective, what is the highest need? What do we need to work on? And oftentimes that ends up becoming either the touchstone, the original event. It could also be the worst incident. So it doesn't have to be their first, it could be the worst or the most recent. And so that's kind of what I would do with either a trauma timeline or a top 10 list. We're using that information to really inform. I don't need the details. The details are going to come out when we're doing processing, when we're actually in the middle of an EMDR session. And that's that desensitization aspect of it, which as I'm hearing Dr. Icahn talk about TFCBT, like all these light bulbs are going off in my head, because there's an aspect to doing EMDR that I think as you become more trained and you I don't want to say perfect, but become more confident, and as a clinician, you do a lot of cognitive interweaves. And those interweaves help to shift the perspective of the original incident. So there's cognitive restructuring that's happening when you're doing EMDR. And I think one of the key differences that I'm hearing, that I often hear from other therapy, and I'll talk about this in the presentation, is that we still kind of do the same thing, but it happens a little bit quicker. And I want to say this too, and I was going to talk about this in my presentation to preface, is that I'm not sure if anybody's familiar with common factors theory, but common factors theory says that there are only 4 common factors that occur in a therapeutic relationship that really determine the outcomes. So there have been maybe 2 or 3 meta-analyses that prove this, and they are the relationship. We already know that, right? You've got to have a good therapeutic alliance. So even from an EMDR perspective, I'm going to make sure that I have a good relationship and that there's a safe space for my client, that I believe that what I'm doing is going to work. So I've got to have hope in what I'm doing. The client has to have hope and belief in what I'm doing. And then finally, that I'm operating from an informed standpoint. So I'm not here to, I know I joked about converting, but I'm not here to say EMDR is the only way, because as you hear Dr. Icahn talking about this TFCBT approach, you can still get to that end goal. So I kind of got off on a tangent there. Narendra, do you feel like I answered your question?
Absolutely. One last thing, I was writing furiously. So you said the 4 factors: relationship, the therapist believes and hopes, the client believes and hopes. And then what was number 4?
That you're operating from an informed intervention, so that you're not just sitting there and talking with the client, you're utilizing some sort of intervention. So whether that be person-centered, Gestalt, relational theory, CBT, EMDR, that you're operating from an informed standpoint. And I think we kind of learn those things, right, as in our work in becoming a counselor. So
thank you, Janelle.
You're welcome.
All right, so we also have been joined by our other panelist, Ms. Jalen Evans. She's an LPC at the Juvenile Justice Center in Corpus Christi. So welcome, Jalen. Thank you for coming.
Hi, sorry I'm late.
You're good. You're good. So our next question is what other information would be useful to know? And are there any potential assessments you might administer for this client?
So I'll go first, and then Jalen, if you want to kind of come in afterwards, since you just joined, welcome. I'm glad to have you here. The pressure's off me. So I did mention that I would do the dissociative experiences scale. And what that does is measure how often is this client disassociating, which is a common reaction or a way of protecting the brain when you've experienced trauma. And depending on that score, it's going to inform me, is this client ready to dive into work, or am I going to have to do a lot more of the grounding stuff before? So that really helps me. And if the score is above a 30 or a 3, then yeah, he's going to need some more work to be able to emotionally regulate. And then I would also do the PCL5. More than likely, he seems like he will meet criteria for PTSD. But that's a diagnostic tool. And then the ACEs, as I mentioned earlier. So those are the assessments that I might administer, at least that I do in my private practice. And then other information would be useful to know. And I think from a sense of an integrative behavioral health standpoint is what other medical professionals are engaged with this client. And if there aren't any other, then we need to get him a referral to see a physician, potentially a psychiatrist if he needs some medication management to facilitate the emotional regulation while we're first working together. I want to make sure that there are other aspects of his life that he's working through. So maybe even is what his employment situation or educational background looks like. That would be important for me to know because that's from my standpoint or from my view is where's he at functioning wise? How impaired is he at this point? And what are some other resources or strengths that he has? And that would be my answer to that question.
So some more information that I would want to gather is I know that some of his protective factors were church and friends and I believe family as well. And so I think for me, finding out how he can connect with those to give him a better support would be helpful. So how involved maybe he is in the church or what kind of activities do he and his friends do to kind of help with maybe some of the coping or helping him in support of his plan for emotion regulation. I do work from a TFCBT point, but I work with teens mostly. And so I know EMDR is really helpful for adults especially. And so I'm glad to hear your take on it, Janelle. And so I know that disassociation is a big one or a big focus in EMDR as well. And so from my point of view, I see some anxiety and some depression symptoms. So I think the GAD-7 would be helpful. And then also the patient health questionnaire to assess for any like depression or any symptoms that he's having there. Because I did notice that he is sleeping a lot and it did talk about depressive symptoms. And then also maybe the PTSD checklist, the PCL5. And so very similar to what Janelle said, I think working on emotion regulation first is very important because I don't think we can talk about specifics or details until he's able to emotionally regulate. That's like opening up a can of worms where you're possibly re-traumatizing rather than helping. And so I think working on I call them the prac skills in TFCBT. Of course, there's no parents involved, but psychoeducation, relaxation, working on expanding maybe his vocabulary with emotions. A lot of people just say I'm sad, I'm tired, and I'm angry, and they don't really have any idea of what different levels of emotions they're feeling. So maybe helping him with that, and then that cognitive coping would be really important for me before we really get into the processing part of his trauma.
Yeah, absolutely. Dr. Ide, is there something that you wanted to add?
Yes, I wanted to share a link with everyone, and I want to say what Jalen and Janelle was sharing. You know, that those are excellent resources, and so you can find a lot of those measures that they mentioned here. I'm going to put it in the chat for you all. You can also find various digital measures from this other website here, and these are specific DSM-5 measures that are within the DSM, but they're accessible to us digitally. And so I'm putting this link here as well. But like, you know, the PCL-5, the life events checklist, the brief trauma questionnaire, those are all very, very helpful measures. And so both websites have access to those measures, and you can print them out. They're available in PDF form. And so I would highly encourage you all to check those resources out and save those links, because then you can find these measures and you can use them with clients. But also, you know, too, I just like interviewing the family. Like when we do a biopsychosocial assessment, it's helpful to kind of get the background, you know, about what had happened. And then of course, clients may not be so ready again to share what had happened or even talk about like the effects that it's had on them yet. So having other sources of information like family members can be very helpful, reviewing their biopsychosocial, and then you'll kind of know then where you can, you know, move forward with treatment based off of what information you gather from these assessments and from the biopsychosocial assessment. So just remember, assessment's a process of gathering information. And so wherever you can gather information, whether it's in a quantitative scale or if it's in some kind of interview, you know, all that can be very helpful to inform you of how to move forward.
All right. Thank you for those resources, Dr. I, and we'll make sure that they get posted on our website as well. So for our next question, so, you know, TexCHIP is really focused on integrated care and collaborating with other professions like medical doctors, social workers, et cetera, et cetera. So for our panelists, if you were seeing Darius as part of an integrated healthcare team, what services do you think as a counselor would be important for Darius to receive from that counseling perspective? And Dr. I, feel free to jump in on this one too.
Jalen, do you want to start first? Do you want me to go?
So I think a psychiatrist, and I know Janelle already mentioned that also, but I think a psychiatrist would be really important in this case. I think it would be beneficial for him. Sometimes we need that extra help, and that's something that could be beneficial for him to be able to regulate his emotions, sleep at night, because he's not getting much sleep. So maybe involving a psychiatrist first would be a big step for him. And even if something that he's interested in, like maybe some kind of like exercise or yoga, you know, some kind of meditation or wellness, mindfulness kind of activity. I think having people involved as well who can help him regulate that way would be really helpful as well. So yeah, I think that first and foremost, a psychiatrist, and then anything else that's kind of going to help him regulate emotionally. I mean, for me, I think if a person is coming to me with resources such as certain family members or even for him, his church, I think it's important for us to involve those people as well. I know we're just talking about healthcare, so a psychiatrist, but I think involving people who are big supports like that and kind of creating a team for that client is something that is helpful.
Yeah, I agree, Jalen. I think I went to one of Dr. Icon's presentations, I think at the site supervision fairs when you talked about integrative behavioral health care. And I've worked in a community mental health agency setting very early on in my career when I was first getting trained to be a counselor. And there are definite benefits to having kind of a central location where providers, whether they're mental health, healthcare, if there's any kind of like a physical component to it, Jalen, like you mentioned, being able to come together and say, this is what we're doing to help this client from an approach that is looking at that person as a whole person and not just from one, I'm only targeting this. It doesn't really talk about substance abuse. I don't know if there's any substance abuse issues for this client, but that would be another component. And I didn't mention that earlier as far as what else I would like to know, but I remember thinking that when I was reading it, it's like, is he using any sort of illicit substances to cope right now? And if so, is that an area that we would need to target? Right now, though, I will say, I mean, I work in private practice and that's my primary setting. And so I think Dr. Icahn, whenever I went to your presentation, identified me as a level 2. Right? Or is that correct? Yeah. Okay. Level 2, because I do receive direct referrals. We have a HIPAA compliant fax and email format where we can receive referrals, and the doctor's offices will send us the face sheet. They'll already have all the insurance information, and then they send us their most recent note, the reason for the referral. And that really facilitates an easier process to getting that client into care versus now we're on the phone and I'm getting all this information from you. And then the opposite of the other side of that is that we can send updates to the doctor's office and kind of say, this is what's going on, this is what we're working on. And that's about where we kind of go from that integrated healthcare team. But I do think that with this client specifically, there could be a lot that I know MHID would be able to facilitate. I don't know, Dr. Icahn, if you want to kind of talk about that from your perspective.
Sure. Yes. So at MHID, particularly in the youth service program, I've also worked for the adult program, particularly for TACOMI, working with adults on probation and parole. But at youth services too, clients, like I was saying earlier, clients would be coming in and it could be a walk-in, it could be a referral from a school or from the juvenile justice center, just depending, different avenues. And when they come in, they get a screening and then they will be scheduled usually on the same day an intake, and the intake is with the counselor. And so that intake can be like 3 hours. So it's very, very thorough, very, very thorough. So they'll complete a biopsychosocial assessment. They'll be administered the CANS assessment, which stands for the Child and Adolescent Needs and Strengths Assessment. You can find that online at the Texas Department of State Health Service website. And from there, based off of the scores and from just like the information gathered at the intake, they'll be assigned a certain level of care. And the level of care is based off of how intense their needs are and how much services they should get. So some clients that are admitted on the lower level of care, they're just assigned a case manager and the psychiatrist. If they're on a higher level of care, they'll be assigned more team members, which can include a case manager, a psychiatrist, a counselor, a family partner, someone who does skills training. And so there's different services that are kind of wrapped around with, right? Our highest level of care is the level of care 4, but there's also a program called Yes Waiver, which is a specific grant funded program. And so let's say they're at the highest level of care now, and they're in the Yes Waiver program. The Yes Waiver program assigns them to all those service providers, and they have regular family team meetings. And these usually happen about twice a month. And the family team meetings is the opportunity for the client and their family members and even friends and any other community resources and supports to come and be a part of this meeting. Sometimes coaches come, sometimes teachers come, and sometimes aunts and uncles. And they go over what's called a family vision, and we kind of talk about like how the family wants to proceed and how they want to see treatment, throughout the time that they're there. What do they want to see, changes made with their family and with the client. Then we come up with a little mission statement as a family, which is very unique to the family, which is cool. And then we go over, their family needs, their family strengths, and we kind of go over this evidence-based system. But at the same time, like I was saying earlier, they're assigned a case manager, which is someone who links them to resources, coordinates treatment for them. So they'll schedule their appointments with a psychiatrist, they'll update their paperwork, they'll even do medication education, and they'll even provide transportation sometimes. And they'll make referrals to other community resources. Maybe they need to have a psychological evaluation done, so they'll help schedule that. Maybe they need to apply for supplemental security income benefits. Maybe, that's what they need, so they'll help them with that. And also, the other team member, like I was saying, is a psychiatrist, or it could be a nurse practitioner that's able to provide prescribe psychotropic medications. They'll have services there too. And what's cool about having this all in-house is that the case manager and the counselor, we can all be present during these psychiatric appointments, and we can know what the client is prescribed. We can communicate our issues with the psychiatrist, and we can get a good idea as far as like what everyone is doing and what everyone is recommending and what services everyone is providing. So it's really good to have this all kind of in-house. Before they even see the psychiatrist, they'll see a nurse, and the nurse will do their vital signs. They'll check their blood pressure. They'll check their body mass index. Sometimes we'll have clients that'll come in and we'll notice that like their weight changed drastically within a span of a month. And so then that might alert the psychiatrist, well, let me do some blood work. I'll order some blood work to be done before I make any changes to the medication, or maybe the psychiatrist will feel like they can make some changes. So that's very important too, that we have that in-house as well. And sometimes clients have medical issues that arise, and thank God we have the nurse there who can come and address any issues medically as well. And so this is all like in one central location. Everybody's very well informed about everyone's role and responsibilities and the services that they provide. Communication is instantaneous for the most part, and so it's very helpful to have an integrated behavioral healthcare team accessible for clients in that manner. And I wanted to provide something else in the chat. I'm going to send an attachment that kind of goes over like a quick reference to common medications that are prescribed by the psychiatrist or nurse practitioner. And so like for anti-anxiety medications, you've got often the different benzodiazepines like diazepam, which is also known as Valium, or there's Librium, there's Traxazine, Klonopin, Xanax. Sometimes there's other anti-anxiety agents, Buspar. And so I'll send all this to you all so you can kind of get an idea. And there's also some of the recommended dosages too for people. And so I'll add this as well.
I'm glad you talked about the psychotropic medications, Dr. Icahn, because it had me thinking that would be more information I would want to get from the client. Like, is he taking anything either prescribed or not prescribed, right? Because some of our clients do. And specifically a benzodiazepine, because in EMDR therapy, they would need to make sure that they haven't taken a benzo. I think it's like a 12-hour period prior to engaging in EMDR, because it numbs the part of the brain that we need to activate. And so it's important to know that too from a treatment perspective. And when you're in an integrated behavioral health system, you would have access to that information, right? Because you would know in their chart what medications they're on, what kind of medications they're on. So that was, it just made me remember that, Dr. Icahn. So.
All right, perfect. Thank you all. So I think we've talked about this before, but part of our TexCHIP grant is that we're going to be focusing on adolescents this cycle. And so if Darius was an adolescent, how might your approach differ with him?
I can start.
Yeah. Okay.
So I actually work with incarcerated youth. And so I work with kids anywhere from 13 to or sometimes 12. We'll get 11-year-olds sometimes, but they'll leave pretty quickly to 17. And so For me, just kind of going off of what Dr. I was saying, we actually have a team. And so the way that we work with our team is we have a nurse, we have a psychiatrist. He's not necessarily always there, but there's somebody who the caseworker has gone to the psychiatric appointments and has come back with notes and the medications that they were prescribed and whether they're taking them or not. So we have a caseworker. We have all the counselors, which is 3 of us, and then 2 caseworkers, and then we have probation officers as well. And so our team is very integrated. There's a lot of communication, and yeah, we're usually able to change things kind of quickly or immediately for, I forgot to mention the families. The families are also on the team. And so, and any other support, sometimes it's not necessarily a biological parent. Sometimes it's a brother or a sister or a grandparent, somebody who is just a guardian to our child or just a support. So we've had also CPS workers on the team as well. Anywho, that was just a side note. But if Darius was an adolescent, I would definitely utilize TFCBT. And so my approach would be different with him because the family would be heavily involved, or whatever caregiver would be heavily involved. So in TFCBT, if they don't have a parent or a guardian, you can actually utilize a case manager or someone who is very close to the client as a support. And so teaching whoever that person is parenting skills would be really important for me. Darius, obviously, when he was an adolescent, had a lot of issues with witnessing domestic violence and things like that. So working with the parents to work on those skills, providing psychoeducation for both Darius and his caregivers would be really important. So talking to them about trauma, the statistics of trauma, making him not feel so alone at that time as an adolescent. And then also, you know, I think a lot of parents especially need reassurance that like, this is not that you're a bad parent. We just are going to strengthen your skills, because a lot of parents I think start to feel like they're bad parents if their kids are in here and they have trauma, or if they were even a part of that trauma, then they feel like it's their fault. And so we try to take a lot of that blame off of the people who are involved. And then again, the teaching the relaxation skills. So in TFCBT, there's an abbreviation practice. So we go through PRAC, which is PRAC. So it's psychoeducation, parenting skills. There's 2 P's, relaxation, and then affective modulation and cognitive coping skills. So that would be the first thing that I would do with the client and his family. And in TFCBT, we meet with the client individually, but you also meet with the caregivers individually as well, which I think is great. For my parents, that is where they really are open about feeling like they're bad parents or feeling like there's nothing I can do to help my child. And they'll cry a little bit sometimes, and we'll work through that. We'll process it. And again, work on those parenting skills sometimes outside of session from the child. And sometimes they'll say things in session with just me that they would never say in front of their child, but it helps me to be able to help them formulate the words to say it in a different way to their child, if that makes sense. And then of course we would work on the trauma narrative and processing these events once he has the support he needs and has the skills to regulate and can take doing the trauma narrative, because that takes a lot of emotion. And again, I don't want to re-traumatize the client. And then some people need exposure therapy. And so being exposed to a trigger or a trauma reminder And that's something that I have not done. I've been trained on that, but I've not necessarily done that with my kids because my kids are incarcerated. And so it's really hard to do that kind of thing. But I have clients who their home is their trauma reminder. And so even having, for right now, some of the things that I'm doing because my kids can't leave is having a parent show, parts of the home. So I guess I am doing it. I am, but it's not, I don't think it's the same as them going in person. But they're able to see parts of their home on Skype. And so that's what we have to kind of compromise with right now. But helping them work through that. So some kids can't even go to their bathroom. They'll be so scared to go to a certain bathroom in their house. Maybe something happened in there. I think baby steps is the best thing. So just being able to pass the door of that restroom, that's like one goal or one step that you can have in therapy. Let's be able to pass that door. Okay, can we touch the door? Can we put our foot inside? Can we put our arm inside? So that exposure is very slow. So that's something that is very sensitive, I think, and something that takes a while with some families. And then I think just enhancing safety is the last, the E in practice. And so say having a safety plan for your family is really important. So with Darius, I think having his aunt is who raised him. So having his aunt create a safety plan with the counselor and with Darius about, what can he do when he's feeling overwhelmed? What can he do when he hears, somebody yelling, or even through the domestic violence, like something could happen and it's going on at that moment. Where can he go? What can he do? Who can he call to get away from that situation? Does he need to call somebody like a neighbor or a family member, or does he need the crisis hotline, or even if he's needing to call somebody to come help his aunt? It just depends what he's needing at that time. So I think having a safety plan for Darius' situation at that time would have been beneficial for him as well. Yeah, sorry, I talked a lot.
That's okay. I mean, I agree with so much of what you shared. I think for me, when I conceptualized Darius as an adolescent, I thought about a couple of things. And of course, I always have that EMDR perspective, right, or lens that I'm looking through. So I would still administer the DES, but there's an adapted version for adolescents, and you sit with them and go through that to kind of see where he's at disassociative wise, and then engaging the aunt who would have been the caregiver, and being able to kind of sit down and talk about the therapeutic process in the relationship. I agree with what Jalen said, like the family dynamics are so important. I might even recommend that the parent, or in this case, the caregiver, engage in their own therapeutic process as they're navigating the needs of Darius. And then I would still do a top 10 list or trauma timeline. I have a handout. It's talks about what is EMDR for teenagers, and it really breaks it down in a way that is easy to read and understand from a teen perspective. It talks about like traumatic events. It's like apps that are disorganized in the brain. And then when something's going on, like your parent asks you to clean your room, that app gets clicked and it's all disorganized. And so it comes out in the form of a anger outburst or irritability. And that when we do EMDR, we're trying to reorganize those apps. We're bringing that memory into the present, reorganize it so that they aren't triggered and the emotional charge isn't present whenever the memory is brought up. So that's kind of how I would conceptualize it. I would also make sure that both the adolescent and his caregiver understand confidentiality and privacy in terms of the counseling relationship. I think that's always an important component to address when you're working with adolescents. and talk about and really outline what is going to stay in this room and what isn't. And legally and ethically speaking, your caregiver has a legal right to your file and to know what's going on. But hey, and I want to be able to give your child some privacy, and I want you to respect that. And know that if something comes up, that there's like a risk-taking incident or issues, substance abuse, sexual promiscuity, self-harming, right? Any of those things, we're going to engage the parent. And I'm going to make sure both the parent and adolescent are very, very aware of that. The way that I would do that, though, would be in a collaborative manner, so that the adolescent doesn't feel like they're being betrayed and it doesn't harm the therapeutic alliance. And I would invite the parent to come into a session to kind of talk about whatever it was that we needed to address. And I always say this to my adolescents when I work with them, is your parent has you here because they care about you. And there are some things that they have to know because they can protect you way more than I can in the counseling relationship. And so I think that foundation is such an important key component when you're working with adolescents, is that that's all out on the table. We know this. I'm not keeping your secrets if they're going to be putting you in danger. And so making sure that the child is aware of that.
Thank you all. I love what you both said. I'm going to just share a little bit. So I wanted to kind of call to mind too how adolescents are in a different developmental stage, right? And when you think about like Erik Erikson's stages of psychosocial development, you know, we got identity versus role confusion. And, you know, Darius right now, he has a rough childhood. He has to be the man of the house. He is familiar with violence. And so those things are going to be processed and experienced very differently for an adolescent versus an adult, you know, but the adults are in their own different developmental stages too. So it's good just to kind of, you know, have that perspective. But, you know, with adolescents, what's so important for them is to have a sense of, you know, to have a sense of sort of like respect, like for a lot of the adolescents that I work with, they are trying to be autonomous. They want to make their own choices. They want to be independent. And oftentimes they find themselves making real poor choices, and that leads to a lot of serious consequences. And maybe they're not ready to handle some of those consequences, you know, and they don't know how to cope with those things. We're all relational beings, but adolescents in particular have a strong desire to be relational. And many of them, you know, find themselves wanting to fit in. And when they don't fit in, then it affects their self-esteem. It affects their sense of self-worth. And so just kind of be aware of those things that are common to adolescents, and knowing that like the way that they might experience things, you know, as an adolescent is very different than what they might experience as an adult. And, you know, they fall into a lot of different risk factors. They may be more prone to running away from home. They may be involved with CPS. They, like, you know, we see Darius possibly having interactions with different gangs in his neighborhood. You know, he gets into fights, and they can fall at risk to other maladaptive means of coping. Substance use, this is usually the time when they first begin experimenting with drugs, and, you know, there's a lot of negative peer influence and peer pressure. So helping, you know, them navigate those moments where they got to deal with peer pressure, they got to deal with negative peer influence, where they got to deal with all these risk factors. They may not know how to, because this is the first time they're ever experiencing these things. So just kind of keep that in mind as well. And then of course, supporting the parents, helping the parents have all the resources to be helpful, to provide structure, stability at home, to be able to be nurturing and caring. Those things are vital, very, very important for an adolescent or a young child, of course, to grow and thrive, you know, in their environment.
All right, wonderful. Yeah, I think that was a really comprehensive overview from several different perspectives. So I appreciate you all on that one. So our last question, because we are a little crunched for time, I'm going to go ahead and ask it anyway. And y'all have already mentioned several resources, but is there anything else that you think might be important, either for Darius as a client or anything that you want to add for our students that might be helpful from a counseling perspective?
There is a disaster distress hotline. I think having those resources available for your clients for when you're not available, or if it's like an immediate crisis, having those resources available for them. So there's, of course, the crisis hotline, even a text line, and then just the disaster distress hotline. This case study mentioned food insecurity, so I just wanted to mention, I don't know if it's already been mentioned, but there are resources such as the food bank. And then also, I just think as counselors, and I know Ash, I've said this a lot of times, I think we're also caseworkers or social workers and first. And so if our families need food, we should help them learn how to get that before we start working on therapy. Because I think that, you know, how can they focus on therapy if they don't have food? And so teaching them how to maybe apply for SNAP if needed, or giving them a resource to be able to go and apply for that, which is food assistance. Yes, Maslow's hierarchy of needs. And so helping them apply for SNAP or food bank. I know at my job, we help our families and we provide free bus passes. So helping them find transportation resources is going to be beneficial. And again, I'm thinking of like some teens, but also our adult clients who maybe don't have transportation to come to therapy, or they're struggling with food insecurity. Yeah, so I think that meeting those very basic, helping them meet those very basic needs is important. Outside of outside of just getting therapy.
I agree with what Jalen said. He's typing in the chat box, getting all excited. Maslow's hierarchy of needs. Yes, absolutely. Referring out, so showing resources like workforce solutions, I think might be one area. Like that's what came to my mind is seeking out odd jobs, maybe even volunteering opportunities in this community to kind of meet that relational component to the community, like Dr. Icon kind of mentioned, we're all relational beings, and fostering that sense of community, even considering a support group. So.
Yeah, I was just going to add, it is helpful to have a list of community resources, because, you know, clients can very much benefit from just knowing where things are in our community. And there are so many resources in our community that we just are unaware of. And one really helpful resource is 211. So for those of you who don't know, you can just call 211, and it's a community resource directory where you can call them and an operator will answer, and they'll tell you where various things are located, where you can get financial assistance, legal assistance, you know, assistance with paying bills, assistance with food, where you can find doctors for different specialties. So 211 is good. You can even go to the 211 website and put in your zip code, and then you can find information from their online directory as well. But it's also helpful to call them. So you can just dial 211, and then that's a helpful resource. Yeah, and so, you know, that's one resource I have. I have like a packet, usually a copy of printouts, and I hand them to most of the clients that I work with.
Wonderful. Well, that pretty much concludes our case study portion of today's training. So I want to thank you all for your input. I think that was very useful. I certainly learned a lot. So Jalen, thank you again for joining us. We really appreciate having your perspective, and you are free to stay for the rest of our training if you'd like, or you're welcome to go ahead and log off. But I think at this time we'll take, is 10 minutes enough? A 10-minute break for everyone? Yeah. Okay, so let's come back at, we'll just round it up. We'll say 10:20.
Thank you for having me.
Yes, thank you.
Thank you.
So we're right at a little after 10:20. Want to get started if not everybody's back yet. I do have sharing capabilities, right, Ashley?
Yes, you should have the sharing capability if you want to give it a try and let me know.
Okay, yeah, let me test that so that it goes smoothly. Okay, what do y'all see?
We see your PowerPoint intro slide.
And that's it? Yay, I did it correctly.
Yay.
Yeah, this has been a lot of trial and error because there have been several presentations where I did not do this correctly. Not on this presentation specifically, but so I've learned to go along. All right, I learned as I've gone along. I think we've got everybody here. I'll go ahead and just kind of get started. First, thank you so much to each of you for inviting me to be here and talk a little bit about EMDR and the role in addressing trauma. I am a EMDR certified therapist. I said that at the beginning. And I also want to just make sure it's really well known that this is not a training that is intended to teach you how to do EMDR, right? There are specific procedures that you go through to become EMDR trained and or certified. And I'll talk a little bit about that at the end of our training and give you a resource if you are interested in becoming trained. I am not an EMDR trainer. I am a certified therapist and I'm a consultant in training. And I'm currently working with Compassion Works to move towards becoming an approved consultant. And one of my long-term goals is to become an EMDR trainer. I just know that that's going to take some time. So I also wanted to kind of share a little bit about how I came into like knowing or being introduced to what EMDR is. So I graduated in 2011 from TAMU-CC with my master's degree. And at that point, I would say I was a CBT and I used a CBT therapist and I used relational cultural theory. Like those were my two frameworks and how I navigated helping clients in need. I did that for several years, became fully licensed in 2013. And then in 2017, I joined a group practice. In 2019, I started to really struggle with like burnout, compassion fatigue. I think I was being triggered a lot during that time as well. I had lost my sister when I was in the counseling program. She passed away due to suicide in 2009. I was like second year of my master's program. And my mom said to me, Janelle, my mom's my first mentor in life. And she says, Janelle, I went to this therapist, Dr. Capps, and he does EMDR. And I'd already been a therapist for a few years. So what the heck is EMDR? I didn't even know what that was. But my mom was telling me, and she said it helped her. So I went to go see him. And I did about 10 sessions with Dr. Capps. I couldn't afford to do any more because he didn't take my insurance and he was only private pay and he charged an absurd amount. But it was worth the time that it took. And at that point, I thought, I need to learn how to do this because if this can help me, then it's going to help my clients. And I was already working with a lot of clients who were experiencing trauma or had experienced trauma. So that's how I kind of got into it. And I've been practicing very actively since 2019. I don't do EMDR in all of my sessions. As I mentioned, I have an integrative approach. I do bring in some CBT, and at my framework and at my core, I'm a relational cultural therapist. But EMDR has been very useful in helping me and my clients move through traumatic events, depressive symptoms, symptoms of anxiety, and an array of other issues. So I'm going to talk a little bit about what I hope that you will get from today. So my agenda is you understand kind of like the history of EMDR, the early work of Francine Shapiro, and a basic understanding of the theoretical underpinnings. Again, I'm not an expert, I'm not a trainer, and I am still learning as I go along. As my consultant, Jordan Schaefer said, you know this much about this much. There's a lot to understand. And there's even still that researchers are still trying to seek to understand is how it works, the mechanisms of change behind EMDR. And then I'll talk about EMDR in practice, and then I will close off today so that you understand kind of what your next steps might be if you decide to move forward to become an EMDR therapist, what the difference is between the trained and certified process. And I'll give breaks routinely. So I'll try to like maybe go for about 40 minutes or so. We'll kind of touch base, see where I'll answer questions, and then take like a quick little 5-minute break so you can stretch and your brain doesn't start to turn to mush by the middle of this presentation, because I know what that can be like. Okay, so the history of EMDR and Francine Shapiro. So in 1987, Dr. Shapiro, who was really like not known in the field of psychiatry or helping, she's taking a walk in a park. And during that walk in the park, she's moving her eyes rapidly looking. And she said she noticed a decrease in feeling distressed, what she was thinking about at the time. And it occurred to her that it was related to the eye movements. So she immediately goes into her colleagues and says, hey, let's try this out. And they begin to try to become desensitized to disturbing events. And then in 1989, she did her first randomized controlled study, which Dr. Icahn can probably tell you the randomized controlled study is like the gold standard in research, right? Is that correct? Okay. And it gets published in the Journal of Traumatic Stress. And in that, she examined one session effects with 22 individuals who had experienced trauma. And she saw that it reduced their distress. Using that scale, the subjective unit of disturbance scale from 0 to 10, she was able to get them down to a 0 by doing eye movements. And at that time, she was just calling it EMD, eye movement desensitization. The reprocessing part didn't come until the 90s, when they started to discover, by utilizing this more, that there was some cognitive restructuring that was occurring in the brain. So I have her book here. This is primarily where I've gathered most of this information, as well as from the EMDRIA website, and then just based on my knowledge from my own trainings that I've engaged in with Compassion Works. And I have those references throughout. But she did publish a book in 2001, and it really lays out EMDR. I've questioned several times, and I know it's a fairly new treatment modality, but I wonder, why aren't we teaching this to every counselor is always my thought whenever I'm talking about EMDR, doing EMDR. I'm like, everybody should know how to do this. And when I finally did get EMDR trained and I understood outside of, being the client, because on the client end, you get a very small snippet of what it looks like. But when I did the EMDR training, I thought, where has this been all my career? Where's this been all my life? I needed this earlier. It could have helped more people. And so I kind of just say that to talk a little bit about the history there and kind of how it came to be. In 1987, that's not that long ago, right? I mean, I like to think it wasn't that long ago, so I don't feel so much, like so much time has gone by. But it still is fairly new. But even though it is fairly new, there are many organizations that actually endorse the utilization of EMDR as an evidence-based modality. And there are several randomized controlled studies and a plethora of research that has come out showing the efficacy of EMDR. So the American Psychiatric Association, American Psychological Association, the International Society for Traumatic Stress, the NAMI, National Alliance on Mental Illness, SAMHSA, the UK National Institute for Health and Care Excellence, the Department of Veteran Affairs and the Department of Defense, the Cochrane Database of Systematic Reviews, and WHO, the World Health Organization, all have come to a space over the past, recent history in the past 20, 30 years, have said, hey, EMDR works. We should be using it to treat trauma. And as far as theoretical underpinnings, I did mention that it began as eye movement desensitization, and the reprocessing part wasn't really brought in until the 90s when they were doing more research. And that over time, research began to affirm the efficacy of EMDR treatment and revealed the adaptive information processing model, which if you decide to get the book that Shapiro wrote, she talks about the AAP model and the cognitive restructuring and the change in perception related to whatever traumatic event was going on. Here I pulled, this came from Compassion Works. I can't remember what study it was from, and I looked this week as I was trying to put this PowerPoint together, so I apologize I don't have it there, but it was a randomized controlled study. And what you're looking at here is on this side, on the PTSD score, so that determines like the severity of symptoms, that score from 0 to 100. And on the lower one, it's time of assessment or week. So 0, 1 week, 2 week, 3 weeks, 4 weeks. So we're seeing a client engaged in counseling, and the lighter blue is eye movement desensitization and reprocessing therapy. And the darker blue is brief eclectic psychotherapy, which, you know, is an amalgamation of maybe solution focus, CBT, person-centered. And we see that they eventually get to the same space, right? Like 16, 17 sessions. And I mentioned that earlier when I was talking about common factors theory, that it essentially, you're still going to have the same outcome. But what you will notice is by sessions 2, 3, and 4, there's a significant decrease in symptom severity. And so that, what that facilitates in my mind anyway, and from my experience, is they're not suffering as much as they were when they first came in. And that's happening a lot quicker for them. And that alleviation of that symptom is something that I have seen for clients where they go, oh my goodness, I'm so glad I feel better. And they keep coming back. So they feel a little bit more invested in the therapeutic process. For this study, this was with 70 participants, and their scores decreased significantly. But again, you know, it doesn't, I mean, at the end, at 17 sessions, they still got to that space. So it doesn't say that other theories don't work, but what we see with EMDR is it works a lot quicker. So I want to kind of take a pause right now and answer any questions or see if anybody just has any thoughts that they want to share. Go ahead, Morena.
You mentioned that the EMDR can be pricey. Give me a range of how much I should expect to pay for a session.
You know, so my rate is $150 a session, but that varies depending on demographics, because in like Houston and Austin, private practice therapists are just, they don't have any certifications or anything, and they're charging $150 a pop. But $150 is kind of high here in Corpus Christi area. So kind of keeping that in mind also. If you have health insurance, your insurance will reimburse. I have another therapist in my practice who's EMDR trained, and we charge $90 for those therapy sessions. Not certified, very early on in practice, and we try to keep it somewhat affordable. But we accept most insurances too. So, and there's other EMDR trained therapists in Corpus that accept insurance. So you might be able to utilize that as well.
Thank you so much.
You're welcome. Any other questions, thoughts? I know when I first learned about EMDR, after I had already been a client, I was like, this is a lot of information and I have no idea what to do with it, because it is from a neuroscience perspective, right? Which I think we're seeing more of the field kind of lending towards the understanding of like the science behind what's happening in the brain. And I'm not a neuroscientist, I'm a counselor, I got my master's degree, and I'm not a doctor. So it was a lot for me to understand. So there are no questions here today. I just want each of you to know that I would view as like, oh, that was a silly question or anything like that. So if there's something that I'm not explaining correctly, or you need more information, please feel free to raise your hand or put it in the chat box. I may not be able to see the chat box, so I'm going to rely on Ashley and Melanie to tell me if there's a question there, and you can feel free to interrupt me. Okay, so I mentioned the adaptive information processing model. And after some research, Dr. Shapiro and her team in doing EMDR began to theorize, okay, this is what's happening in the brain when we're doing EMDR. So we have two types of memories that our brain stores, the implicit and the explicit, or non-declarative and declarative memories. So implicit memories, those are stored back here in this part of the brain that I can never remember what it is, but it's back here, I know that. And that's where we store memories like walking, talking, running, riding a bike. We don't think about those memories, right? But you know, the saying, it's like riding a bike. You get back on, you just know how to do it. Your body remembers. Well, that's the same space where we store traumatic memories. And so when we look at a client like Darius, right? So like when I read this case study, I was like, oh my gosh, I want to do EMDR on this client. He's in the environment where his body's remembering what happened to him. And he's having these responses because that's what his body's telling him he needs to do to stay safe. And that's where it's stored in his brain. Explicit memories are more things that we remember, that we are taught, that we can access and go, I know when I was taught this information. What EMDR says is that sometimes we naturally organize and store information, even traumatic events, in our adaptive neural network. So we may be able to move it into a space of being very well organized. So that even, and I think you might see this with some clients where we see post-traumatic growth, or maybe even like what we call resiliency, right? You see clients come through and they've gone through some of the most difficult experiences, or they faced loss. The last 2 years have been extremely difficult for even, I mean, the entire world dealing with COVID, right? We already have within us everything we need to be able to overcome traumatic events. So sometimes our brain does it for us. Other times, the memories are disorganized and they become stored in our maladaptive neural network. And this happens, at least the theory behind this is that when we're under stress, cortisol levels are expressed, right? And that depletes the part of our brain that I can't remember what it is, but I know it's there. It depletes that part of the brain's ability to cope. And so you might see with little t traumas, there's an expression of cortisol levels, but there's a way to mitigate that, right? And then there's also some environmental things that might provide support, like a relationship. A strong, healthy relationship can help with the repairing. But when there's too much cortisol, or there are several instances of acute trauma, it depletes the brain's ability to process and organize the event into the adaptive neural network. So that is kind of like, in a nutshell, what adaptive information processing is. Does anybody have, or what it is? I mean, it's so much more complex than that, and it's a lot to that I don't have the knowledge to teach. But that is really what's at the foundation of EMDR and how it works, or how they theorize it works anyways. Does anybody have any questions about that? Or thoughts? And that's like, no questions. I can't see everybody, by the way. So if you raise your hand, I can't see you.
Hey, hi, Janella. It's Norina again. Just real quick, are you going to be able to give us your slide set here, or shall I take copious notes?
You can have, I think this is recorded, right, Ashley? Are y'all going to be posting it, or? Yes.
Yes, it's recorded and we'll post it.
Okay.
Okay.
And so on the memories, it doesn't matter how old. Could you remember things from, first years, first 18 months? Do we know anything about that?
I don't know everything about that, but I know a little bit, and I've been studying it recently. I highly recommend that everybody get a copy of this book. I'm only like a third through it at the moment. It's the Pocket Guide to Interpersonal Neurobiology, and Daniel Siegel is the author. And it's obviously not a pocket guide, y'all. It's kind of like a joke, I think is what he meant, because you can't really put all this information in there. But to speak to what you're saying, Norina, is yes, there are groups of mental health professionals who are doing EMDR on what is known as womb trauma.
Yeah.
Trauma that you've experienced in the womb. And what this book is saying, this interpersonal neurobiology book, at least as far as I've gotten with it, is, and I'll put it in the chat box at the end too, y'all. What I'm reading, and I've read this in My Grandmother's Hands, Racialized Trauma, and I think we're starting to see this. And if you go to the EMDR website, there is even more information available there about healing racial trauma. But there is theoretically the brain, what has happened, or what they're saying is happening, is that even our ancestors who've experienced trauma, it changes their brain and it changes what they pass down onto their children. And so when we look at racialized trauma, right, where there's a history of, in my opinion, grotesque oppression and objectification of groups of people, and how that impacts down the line, right? So our neurobiology says that it does, that we get our parents' coping skills, basically, or lack thereof, right? So, and there's a whole, and I don't have all that information, but there's a whole lot of information out there on how do you heal those parts of the brain. And that's a lot of what EMDR shows, is that, and we know this, that there's neuroplasticity. We have the ability to heal, to continue to learn, and to rewire. I saw you doing this, Mira, and it made me think of rewiring.
Yeah, exactly. Yeah, some of the things that I've looked at, and this is related to when a child is in utero and the mother is in trauma, continuous trauma, that the cortisol that is trying to help her cope is also basically, injected in the uterine fluid, and that this child is literally covered in cortisol the whole 9 months. And there's got to be some effect from that. And I believe that it comes up as reactive attachment disorder. But, we always think it's after the child is born, but there's got to be something, because I have an adoptive child that we've done everything that I can think of. And I think that this child just was in so much trauma with his birth mother, who was 15 years old, and in an abusive relationship. And I do know the background, and so it all makes sense to me. And I'm wondering, could my child be helped with EMDR and going back to memories, and I put memories in quotes,
Right.
of his utero experience that maybe could be rewired.
Yes, yes, and yes.
Oh,
And it would be about finding the right EMDR therapist, which I'll talk a little bit about as well, right? Because we've got to stay in our lanes, know our expertise as therapists. But there are therapists who are specifically trained on wound trauma and
okay.
how to heal that. Pretty sure most of y'all might be familiar with Body Keeps a Score. And if you're not,
Yes,
you need to
yes.
become. Yeah.
Yeah.
So this is very much aligned with that idea of our bodies remember the traumatic events, and they can remember these events from even in the womb. And there is a way to begin healing, and you can do it through EMDR. And that's not the only way. Again, I want to make sure that that's clear, but this is one way that you can facilitate healing and rewire the brain so that the traumatic incident is moved from the maladaptive neural network into the adaptive neural network. That's where the cognitive restructuring is happening.
So Janelle, Matt put a really interesting point in the chat about when you're thinking about lasting change, how does age and neuroplasticity related to age impact the ability to have lasting change?
Yeah, and that's where with EMDR, I think is one of the biggest differences from CBT, is that there is a rewiring that happens so that the change is long lasting. Now, that doesn't mean there won't be additional traumatic events that occur that need to be healed. But what we do see, at least the research shows with EMDR, is there is longer lasting change outside of therapy, or the ability for the brain to rewire. It sticks, I guess, essentially. So. Does that answer your question? And age, there isn't any, I don't have any information. That doesn't mean there isn't any. I don't have any information that would indicate that age would matter as far as long-term change or the brain's ability to bounce back, so to speak, right? Or to engage in EMDR. But I know there are different approaches that can be, there's adaptive protocols when you're working with clients at a younger age group, because their brain does process information differently. That would be like 13 and under. So you going like this, Matt? Does it answer your question or?
Yeah, I'm just trying to think about it in terms of based on how I understand neuroplasticity and age-related learning co-occurs. So it's trying to apply the concepts here into that understanding that I have, and just try to work that out in my head on how what kind of correlation exists between the two, positively and negatively. That's all I'm thinking.
Yeah, you're coming up with a research idea is what I'm hearing, Matt.
I'm stopping at the master's for a reason.
What?
I love to read research. I don't want to do it. I'll read your research.
You can still do research.
Research, and I'll read Dr. Mosley's research. I'll read all your research, and I'll love it.
And you'll offer up your practice as participants. Maybe.
There you go. Yes, I will be at your conferences too.
Yeah. I mean, what I think with EMDR, I mean, what the AIP model is essentially saying is that those memories can be reprocessed into a way that the perspective changes, is essentially how I understand that. And this can happen at any point. Now, if there's traumatic brain injuries, it's not going to fix parts of the brain. If the brain is injured, the brain is injured, right? That is outside of the scope of EMDR, at least to this point that we know of. But when we're talking specifically about the way that we process information and the way that we store memories and how they inform our responses to current and future events, this is where EMDR really kind of creates change or facilitates change. Good questions. Okay, so I'm going to move on to my next slide. So EMDR in practice, it helps children and adults of all ages, and therapists can use EMDR therapy to address a wide range of challenges. So it can address pain, performance anxiety, personality disorders, PTSD, incidences of sexual assault, sleep disturbances, substance abuse, anxiety, panic attacks, and phobias. It can address chronic illnesses and medical issues, depression and bipolar disorders, dissociative disorders, of course, right? I mean, there's that integration that's occurring in the brain, eating disorders, grief and loss, and violence and abuse. So there's a wide range of symptoms or challenges or issues that clients may experience that they come to EMDR to receive assistance in overcoming. Now, that doesn't mean that every EMDR therapist can address all of those issues, right? That you've got to have expertise and practice in working with that specific population. So someone with substance abuse issues, I wouldn't necessarily be able to assist them. Someone with a OCD or you know, something like a chronic illness, those are things that I don't have enough information at the moment to treat. Doesn't mean that I won't in the future, but right now I'm going to know my limitations. And I think that's always important as therapists, is that we know our limits. We can't help everyone. We're not supposed to help everyone. And that is the importance of having friends in the community, right? Because I can't help you, but my friend Dr. Burks can, right? I can't help you, but Dr. Icon's amazing. Go there. And knowing and building those connections as you continue to work in the field. Okay, so symptoms of traumatic stress. I took this directly out of our DSM. When we're looking at identifying trauma, we're looking at it as a sense of like, it's not just one or two symptoms, because sometimes it could just be anxiety or depression, right? So we want to see that indicator that there's that we're impaired. The social, occupational, health, relational, and other areas of functioning are being affected, and that these symptoms are recurrent, they're intrusive and involuntary. And the symptom list is hypervigilance. So that perception of fear or danger, right? Like I've always got to be on edge. I like to explain this to clients in a sense of like, you're in survival mode. We're not meant to live there. Let's honor that part of our body that's keeping us alive through this terrible event that's occurred or did occur, but we're not going to unpack and stay there. But when we see hypervigilance, we know that's an indicator. An exaggerated startled response, again, that's something that their body is doing to keep them safe. Flashbacks, that's intrusive, that's involuntary. It takes them back into the traumatic event. They might experience nightmares, night terrors, sleep disturbances. I think when we look at EMDR, that's like the number one thing that we see, right? Like clients are coming to us and they're not able to sleep. Why? Because they can't get into that resting state. And one of the indicators that we know it's working is they're coming back and they're like, I'm sleeping better. And we're like, yes, that's amazing. That's what we want, because sleep is so connected and tied into your well-being. Like, do not bother me after 8:30 p.m. because I'm going to sleep and my phone's on do not disturb. I take that very seriously as a clinician. And it took me years to get to that point because there's, you know, in our culture, there's this hustle. Like I stayed up till 2 a.m. and I was up at 6. Like, what? No, you should be sleeping so your brain can recharge and come back the next day and engage in the work that you have to do. So anyway, but that's my little, I always talk about sleep. I think that's important. Irritability is another symptom of traumatic stress. Agitated behaviors. I don't know why 24 is written on there, y'all. That was an accident, typo. And then that they might be experiencing some anxiety or depression, and that it's kind of correlated in with all of these other issues. So that's what we're looking at. I did mention earlier the what tools I use to assess for these symptoms. And of course, some of it is self-report, the intake, that kind of thing. But there's also this element of, I want to see what your scores are on the PCL5, the DES, the ACEs, the PHQ-9, and the GAD. All of those are going to really help me and inform me about what their primary diagnosis is, and then maybe their secondary diagnoses. So what I'm going to do right now is we'll take a little break. I do want to, before I move into this next section where I really kind of get into the meat of EMDR and how it works and the phases, does anybody have any questions or even thoughts that you want to share, or something that was like a light bulb moment for you today?
I think seeing the comparison of kind of, I guess, other therapies in comparison to the EMDR graph was really interesting, and just the kind of serious improvement that was happening. Whereas it was happening over time with the other one, it was just more helpful to engage in this. So I think that kind of shows that this is a relevant and important medium to consider when working with people with trauma.
That was so eloquently put. I really appreciate that. Yes, absolutely. All right, I'm gonna let y'all go off to a break. Come back at like 5 minutes, so 11:05. Is that okay? Give you just enough time to stretch, grab something. Okay. All right, we're at 11:05. I'm going to check the chat box. I told you my dog was going to make an appearance today, did I not? Hey, Joan, can you come say hi to everybody? Watch this. That's what she usually does, and then she runs away from me. She's only 3 months old, so she's still a baby, almost 4. Okay, so okay. Thank you, Dr. Icon. She is adorable. I love her. She's actually been accompanying me to the office, and she is like an excellent little therapy dog in training. I mean, my clients light up when they walk in the door, and she, like every single one of them, she like wiggles her tail and she acts like they're the most exciting part of her day. And then after that, then she sits next to them and relaxes while they're on. She's like, okay, mom, I've done my part. Now it's your turn. So she's been a wonderful little addition. Okay, so I hope everybody got to stretch a little bit, maybe take a little bit of a break and refresh the brain. I want to talk about the 8 phases of EMDR. I think that sometimes, you know, as is with most of the stuff in our profession, there's a lot of misinformation about what actually goes on when we do therapy. And one of the things that I've commonly seen with my clients when they come in, or I've even heard other people say is, when are you going to move my eyes? Like, that's what we got to move my eyes. Like, that's what we're going to do, right? Because that's going to help me feel better. And they want to dive right into that. Now, there are some situations, and there's an adaptive protocol for recent events where it was a very traumatic issue, and we want to like address that right now, because that's going to bring us more symptom reduction than some of the emotional state change exercises that we would traditionally start with for complex PTSD and people who have like high dissociative scores. But that's not kind of what I'm talking about today. So I'm talking about a client who's coming in and maybe they want to do EMDR, maybe they don't even know what it is. I treat every single client that comes in my office as somebody who's going to do EMDR because I think it's going to help them in some way. And we know that a high percentage of our clients are coming in and they have a history of trauma, whether that be little t or big T trauma. There's something there that we can work through. So I want to make sure that I understand the needs of my client. So I'm going to do a thorough intake, the first phase, history and treatment planning. So this is going to help me understand and discuss the client's history. I'm going to know as much as I can. So this might be in the form of your clinician's office if they have a biopsychosocial that they utilize. That's going to be part of the intake. If there's a standard intake questionnaire that they complete, that's going to be part of that history. And then the treatment planning, that's a collaborative process between you and the client where you're identifying, these are the goals that I have. This is how I know I'm going to meet those goals. And this is the work we're going to do together as an intervention, because I always operate, it's a collaborative approach. I could sit with you here 1 hour once a week, but there are all these other hours in the week that you're going home. And if there aren't appropriate changes being made outside of therapy, then are we really doing any work, right? Or the way I like to kind of like lay it out for clients is you can go to the gym 3 times a week, but if you go home and you're eating tacos and sodas and bags of chips, you're not going to see that much of a difference, right? So it's just one piece of the process in creating change. In that history and treatment planning, so that collaborative process, I'm also going to be looking at stability. So this came up earlier, I think it was during our panel discussion where we were talking about they're in an unstable environment. Some of our clients are coming to us and they're living with the perpetrator, or there's a lack of support. So we've got to take that into consideration. And that's the part of the good history intake process, is knowing, is my client still in an unstable home environment? Are they Sorry, I hadn't pressed play over here, distracted me. I'm trying to record for time, I apologize. So are they still in that environment where they are at risk? It doesn't mean we don't do EMDR, but we're gonna take that into consideration. So the history and treatment planning phase, it takes time. It can span between 2 to 3 sessions. You want to make sure that you're getting as much information from your client as possible, because all of that is going to help you conceptualize their readiness. The preparation phase, so this is phase 2. And in preparation, this is where we're maybe doing safe place. Well, we should always be doing safe place. Doing safe place, practicing light stream, which I'm going to give you guys I hope you will engage with me as we do light stream at the very end of our process today. I want to kind of demo what that looks like. Maybe we're doing container. We're preparing the client to engage in something that is very intense. We're asking them to revisit their trauma with us. You've got to prepare your clients to go there. And there's a process, and what that looks like in EMDR is the emotional regulation, making sure that they understand what EMDR is. So having that conversation, this is where you give your elevator speech, right? I'm going to move your eyes. Theoretically, the eyes are connected to the limbic system. That's where your implicit memory is stored. We're going to bring that memory up into the working memory, and we're going to reprocess it so that it moves from your maladaptive neural network to your adaptive neural network. So that when you look back on the incident, we're not erasing it. What we're doing is decreasing the emotional charge. You're still going to remember the event. I sometimes joke, and not everybody gets it, especially not my teens, but it's not eternal sunshine of the spotless mind. I don't know if anybody's ever seen that movie. It's a good movie. Yeah, we're not doing that. And it's not hypnosis, right? So it's another thing. I also, in preparation, I want to see what's going to be the best way to do what's known as bilateral stimulation. So that's what the eye movements are, right? They're BLS, that's what they're called. But sometimes you might have clients who struggle with that. They are not able to stay focused on the eye movements and the memory, or they would just prefer to do another method. So you want to do that in preparation. Do you want to do tapping? Would it be easier for you to do an audio? The preferred method is eye movements. I typically do eye movements. That's where I start. I get them practicing with that first. Then, if they say, no, that's not going to work for me, then we might move into another way to do bilateral stimulation. So that all happens in preparation. So if you're thinking about being with a client, right? When they first come in, I am working with them from an EMDR framework. We're not even going to start eye movements to probably session 5, maybe session 6, because this all takes time. And in those first few sessions, I'm also developing that alliance. There's a safe space here. You can go to that dark memory, that scary space that you've been struggling with, and it's going to be taken care of here. This is going to be a safe space for you. For some clients, that's easy. They feel that right away. Other clients, it takes time because they have not felt safety. They have not been able to experience a sense of calm. And so always being mindful of that when you're working with clients, at least from an EMDR standpoint. And then assessment. So this is not what it looks like. When I see the words assessment, and it takes me always, when I see assessment, it takes me a few seconds, I think, to go, nope, it's not DES scores, PCL5, GAD, PHQ-9. In EMDR, what assessment is it's actually outlining the protocol, or I'm sorry, the protocol that we're going to go through. So when you hear about EMDR, or whenever, if you decide to do EMDR, you're going to hear the term protocol. Each EMDR session has a specific protocol. Phase 3 of EMDR is getting that information. So you're going to ask the client, once you're in phase 3, you ask, what's the incident you want to work on? Sometimes you already have it outlined because you've gone through your top 10 list, right? You already know. Sometimes they come in and they're like, nope, I want to work on something else. And that's okay. We're going to identify what the incident is. Then we go in, and when you think of this original incident, what is the image that comes to mind that represents the worst part of the event or the most significant part of the event? Then you have them identify their negative cognition. So this is some CBT there, right? So when you think of this memory and that image, what is the belief you hold about yourself now? And this is in the present moment. So this is that dual attention to the past memory and the present moment, because we're really targeting how they view the event now. We're not targeting the memory specifically because we're bringing it up into the working memory and how their neural network has, I don't know how to say this, but how they're perceiving the memory now, right? We're not like going back in. And that's a common mistake that EMDR therapists, and I did it too, my consultant pointed out to me whenever I was practicing, was you've got to keep them in the now. So you ask them, what is their negative belief? So it's a negative cognitions, it's the shame-based, it's the irrational thinking, distorted cognitions. I am bad, I am dirty, I am dumb, I am stupid. Those are some of the negative cognitions. So you identify that with the client in a collaborative manner. Then you ask them what they would rather believe about themselves, because this is laying the foundation for the cognitive restructuring piece. So you ask them, what would you rather believe about yourself when you bring up this incident and this memory? I'm sorry, this image. And it might be, so it's usually the opposite. So like, I am bad, I am good. I am dumb, I am smart. I am helpless, I did the best I could, right? And that one, they say with EMDR, it's not like super important that the positive cognition be accurate, because when you move into installation, it changes sometimes for clients, and they might not even be able to bring that up if there's a severe amount of trauma. So we do the best we can with positive cog. You get that for them and with them. Then you measure their validity. So again, this is an assessment phase. When they bring up the image and the words, I am good, how true is that to them right now? Gut feeling, not the thinking brain, the emotional part of the brain. What do they feel? And should usually range below a 5. Sometimes it's a 6. Sometimes it's a 1. It's completely false to them. They don't believe it at all. It doesn't really matter which one it is, but we're going to measure that because that's going to be an indicator later on if what we did with them was effective. Okay, this is our assessment space where we're really starting to outline what we're going to measure. So then we move into, when you think of the original incident, that image, you really want to paint that picture. They should paint that picture for you. And those words, I am bad. What feelings come up for you now? Again, keeping them in the present. So all throughout this, again, they're getting activated. They're coming into the memory, right? But you're keeping them also in the here and now. And they say, I feel sad, I feel scared, I feel anxious, all of these things. Okay, on a scale of 0 to 10, how disturbing does that feel? So again, this is the measurement that we're gonna look at to see if what we're doing is working once we're done with processing. So they'll tell you 0 to 10, maybe it's a 7. Then you want to identify where in their body is this disturbance presenting for them. So is it in their heart, their chest, their solar plex, their stomach, their legs, their hands? It doesn't matter where, but where is it for them? You want to bring them back into that awareness and into their body. And the theory behind that is, right, like our body keeps the score, our body stores the trauma. And we want to, the way I like to think of it is, we need to go in there and floss that tartar out, get that. We need to get in there. That's what I think of it in my brain, how it makes sense to me. So that's assessment. So you've got all this information from the client. That's phase 3. And this happens in the very beginning of your session, once you've already done history, treatment planning, and preparing. Then you move directly into the processing. So you say, as we've discussed, you're in charge. If you need to stop, we will stop. You say the word stop or raise your hand or whatever agreed upon indicator that they need to demonstrate that they're becoming too overwhelmed or it's becoming too overwhelming. Because what happens when you're doing EMDR is the client may be re-experiencing, right? That's that desensitization piece in the processing. So they may say stop, but maybe they're telling the perpetrator to stop and not you. So it's very important to have that understanding of what it means when they say, are we going to stop? Or this is my cue word, or whatever it might be. And it's not always that intense. I don't want to scare y'all like they're crying, and it isn't always that scary. I think because sometimes as a therapist, I think that kind of seems scary to go there with your clients. Typically it's, there is some emotional charge that's brought up, but at the end, there's a decrease in that. And almost like a sensation of relief that you can see in the client that they like basically were able to become desensitized to the incident. Processing can take, I mean, you can spend sometimes 2 to 3 sessions on one target. Sometimes it can be one session. Yesterday, I was in an EMDR training, a basic training with Compassion Works, and I loved the way that the trainer described this. And what she said was, it doesn't matter how long it takes you to get there. The only thing that matters is that you've gotten there. So sometimes when I drive home from work, I stop at the corner store. I stop at HEB. Maybe I take the long route and it takes me 20 minutes. Other times I come straight home. It takes me 7. It doesn't matter. The point is that we're getting from A to B. That's what we want to see with EMDR. So we start from that high SED level and we're getting down to the either an ecological 1 or a 0. So I'm gonna, so that's assessment. That's the assessment. And then I kind of talked about desensitization. That's phase 4. That's where we're doing the bilateral stimulation and we are becoming, the client's becoming desensitized to the event. Before I move into this next phase, I know that was a lot of information. Does anybody have any questions about what I've shared up to this point?
Hi, it's me again. You
Yay.
talked about in the preparation stage, you said some terminology that I was not familiar with, container, safe something, and one more that I didn't get written down. Could you recap what those are and what the names again are?
Yes. So safe, calm place is an EMDR technique where there is eye movements. And what it does is it helps the client understand how to experience emotional state change. You might already be doing this with clients. You may have learned to do this with clients in a different way. One of the major things that I think is different is there's a specific protocol that you go through and you do eye movements to help with the installation. It's a space that the client can go where they feel completely safe and calm. That's what safe, calm place is. And it's a specific procedure that if you go to the right EMDR training, you should get trained on how to do. And I do safe, calm place with every client. I mean, okay. It's a good way to help them understand like, oh, wow, I can manage my emotions. I have that skill. Container is another EMDR tool. Really what I think this is it's a way to compartmentalize, help the client to be able to compartmentalize whatever it is that they are bringing into session. It's a way to set aside information that you can't review or handle right then and there, but we know we're going to come back and we're going to open up that container. And so it's a creative exercise. It's guided by the clinician. You have them in their mind imagine a container of any kind. It can be small, large, whatever they want. I've had clients say it's a little treasure box. Some clients it's a Tupperware plastic lid. Some clients it's a purse, mason jars. It can be anything. And then you have them practice placing thoughts, ideas, emotions, memories, images into that container. And then light stream, which is what we're going to do today, is another EMDR guided imagery technique that helps to decrease a disturbance that's coming up for the client. So these three things I feel like are so important when we're working with clients in the preparation phase, because you might have a session, more than likely have a session that's considered incomplete, especially if you work in a managed care setting. You can't bill typically for 90-minute sessions. It's just not really something that you're able to do. So if you're working within a managed care context, you've got a 60-minute window. And again, sometimes it takes clients 20 minutes to get home. Other times it takes them an hour, right? So you might have to span over a series of sessions on one specific target. What that preparation phase does is it creates the ability for the client to leave that session and not be emotionally charged. They're
Right.
able to stabilize when they leave.
Yeah, those are powerful techniques to have. Yeah, thank you. Thank you for expanding on that.
You're welcome. Thank you for asking.
I have a question, if I may, ma'am, please.
Yes.
Okay, so I have a client right now. It's born female, but identifies himself as a he. And so it's
Okay.
15. And so he was sexually abused. And he cannot hear or for under any circumstances the word rape. We cannot say it during session. So that would be a good place to put it on the container, right?
Yeah, you could use that like to place it in the container so it helps to kind of contain that and kind of set it aside. But the
Right.
thing about containers, you want to make sure that at some point you're going to open that back up and we're going to deal with it. Because
Okay.
what I tell clients is like, eventually that container is going to get too full because that stuff grows, it doesn't stay small, and it's going to burst open, right? And that's just like a visual I like to give them. So we've got to open the container up. We can't keep it there,
Okay.
but we can set it aside.
Perfect. Thank you.
You're welcome. Any other questions? Okay. Just making sure I'm doing good on time. Okay, so we have just finished phase 4 of desensitization, meaning the client has gotten to their destination. They are at a subjective unit of disturbance that is a 0, meaning when they go back in and check in on the original incident that we're talking about, there's no disturbance. There is is it a caveat to that or like an exception? So when you have clients who have experienced sexual assault or assault of any kind and or grief, they're never going to look back on those experiences and go, oh, I learned from it. Oh, I understand why this happened, right? That's a horrible and a terrible thing that happens. And it's nothing that can be explained other than someone took advantage of somebody else. And so for those clients, it's very important that we let them know that they may get to an ecological 1, and that's as low as they're going to get. There will be some disturbance, but it won't be at an 8. It won't be debilitating. They'll be able to hear the word rape and not be activated. When we're doing EMDR on grief and loss, it's the same thing. They're always going to be sad. They're going to be sad they miss that person. That's a normal human emotion, but they're not going to be so sad that they can't get out of bed and aren't relating to those around them. So it's important to remember that whenever we are doing EMDR, that we're not sometimes able to get down to that 0, and that's okay. An ecological 1 is what Dr. Shapiro referred to as an appropriate SUD level for clients with those types of traumas or losses. And there may be others too. I mean, those are just 2 examples that I'm kind of thinking of. So then you move into phase 5. Now you're going back to that validity of cognition and the positive statement. So you ask the client, the EMDR therapist would ask the client, when you think of this original incident and those words, I am good, how true does that feel to you now? And does that still fit, or is there a better positive statement? Sometimes it changes. Sometimes they say, I feel like I'm empowered, feel powerful. I feel more aware, whatever it is to them. You have them measure and you want a 7. If it's not a 7, they're at a 6 or a 5, no, there's still a blocking belief there. We got to go back in and continue doing desensitization. We didn't get all the tartar out. The hygienist is now here and we're like, hey, there's still some tartar in the back part. We got to get that out. So we go back into desensitizing. The goal here is to get their subjective unit disturbance to a level 1 or 0 and their validity of the cognition to a 7. That's phase 5. Sometimes it gives us more information to go back into desensitizing. Sometimes we can move right through it. Then we go into our body scan, phase 6. Now we're going to see, is that disturbance completely gone? So now you're going to have the client from the top of their heads all the way down to their toes, kind of tell you, is anything coming up for you? If it's a positive sensation, let's enhance that with some eye movements. If there's this negative sensation, what's happening there? Is it related into the traumatic event that, again, do we need to floss a little bit more? So we're checking and we're assessing, did we get everything out? Then you move into closure. If you have an incomplete session, you're moving straight from phase 4 to phase 7, because you're going to come back in your next session and revisit whatever the incident is, because you didn't get it all out. If you did have a complete session, you have a closure, we let the clients know, you know, what you did today was, I mean, we honor it. However you want to close up the session. I typically will say, you know, the work you did today was brave. Thank you for being here with me and doing this work. If you need me between now and next week, please call if something comes up. And then, you know, we're scheduling our next appointment and we're agreeing to come in the following week. I don't do EMDR, try not to. Sometimes clients don't tell me, but I try not to do EMDR unless if they're going to be gone a week. And I'll never do EMDR if I'm going to be out. So I know I'm going to be seeing that client in the following week because stuff comes up, processing continues. They might have new memories, new insights, dreams. That's all their brain kind of making sense of what they process, but then also it's linked in. Sometimes, remember how I mentioned earlier, there are themes. That memory might be, it has like a different node, and now we need to go down that node and process that out. And it may be linked in with the other memory. So we've still got some more work to do, essentially. So sometimes I'll give them a log they can write down, or I'll just tell them to write it down on their phones. They can bring it back into their next session. So closure can vary. If it is an incomplete session, meaning they didn't get to a 0, then that's what we're going to do. Let's go to our safe calm place. Let's put the contents in the container, and we're going to open that container when you come back in next week. Or let's do light stream. Depending on how intense, I might do all 3. Whatever I got to do to make sure that client is going to leave my office feeling safe and not activated. And then when they come in, phase 8, that's the next session, the reevaluation piece. So this is when a client comes back and you're doing the protocol, but it's varied. You're not referencing the negative cognition. That's a whole different kind of a protocol. It's not the standard protocol, but you're looking at, does anything come up because maybe something else came up? We missed some tartar. We need to do some more flossing, or maybe they're fine and we can move on to the next target within that theme. So those are the 8 phases of EMDR. As you can see, it is not one session. It's not one 90-minute session. It is a process that has a starting point and hopefully a completion point. You will not do EMDR every time just because you're an EMDR therapist, but it is a useful modality for helping decrease emotional charge. There's a lot of EMDR therapists who incorporate positive psychology. There's things like future templates that you can do to where like you're helping install positive thoughts for future events. There's a whole thing called resources. There's a lot more depth that of course this training is limited in, or this today what I'm doing is limited in providing. But this is the 8 phases of EMDR is the standard procedure for how you start and you complete with a client. Does anybody have any questions?
Yeah, it's Noreen again. I was typing furiously. Can you just give me a couple of sentences on the body scan process number 6? I didn't capture that.
Yes. So the body scan, essentially what that is it's after installation. So the client's like, when I think of this memory, I believe on a scale of 1 to 7, it's completely true that I am good, right? So yay, we did it. Then now we're going to do the body scan. So now I want you to close your eyes. I'm going to tell the client this. I want you to close your eyes, or from a trauma-informed standpoint, this is really important, or lower your gaze. Sometimes it can be triggering to tell the client to close their eyes. So I'm always mindful of that, especially in doing EMDR work, because there's a lot of activities where it will be helpful to them to close their eyes, but I want them to lower their gaze, and I give them that choice. So I'll tell them either lower your gaze or close your eyes. And I want you to just scan from the top of your head, space by space, going down to your shoulders, your stomach, your legs, your knees, your feet. If you notice anything, any sensations that are coming up. And so they might say something like, yeah, my tummy's grumbling because I'm hungry. That's not really related, but let's go ahead and just see what's there. It might be related, we don't know. Nope, still just hungry. It's almost lunchtime. So that's okay. But they might notice like, I feel this warmth in my chest. I just feel so good. I feel like my grandfather's still here with me, even though he's not physically here. Okay, let's notice that feeling. Go with that. We're going to do some more eye movements and really enhance it. This is where we want to just make sure that we got all the tartar out. And if we didn't, and that good feeling, we really want to expand upon that good feeling too.
Thank you.
You're welcome. Okay, so we are almost to noon. Still got a few more slides. I'm going to go on to the next one. And okay, so I've kind of already covered some of this just based off of questions, but client and therapist readiness from an ethical perspective, this is very, very important. And to always remember that as therapists, our number one thing is to do no harm. Just because I'm an EMDR therapist doesn't mean I can treat every single client based on their symptoms. I've got to stay in my lane and know my skill sets and my knowledge. So that's a very, very important key component to being an EMDR therapist, is that we specialize in whatever the needs of the client are. We want to make sure that we've done the appropriate scales. I always do the PHQ-9 and GAD for every single client. When they're going to do EMDR though, I really need their DES, I need their PCL5, and I want their ACEs. Those are going to inform me of where the client's at symptom-wise and their readiness to engage. Because I may have a client come in and their DES score is really low. They do meet criteria for PTSD, but they're not very dissociative. So maybe all I'm going to do with them is save Complace and Container. I might use Lightstream. I don't have to do it with them right away. I might use it if I need it. But then I'm going to get into processing because this client wants to feel better now. They have supports, they have resources, they're in a stable environment, they're high functioning. They just want to feel better. That client's way more ready than somebody else who's got a DES of 5. And then the emotional regulation component, which I feel like I've harped on a lot, but I feel is so important with EMDR because I've had clients come to me and say, yeah, I've done EMDR before, but it just was so scary and it felt uncomfortable. I didn't want to do it again. And to me, that indicated that client was not ready. That client didn't have the emotional regulation. Maybe the client wasn't in a safe environment at the time. There was some sort of instability. We definitely don't want to be doing EMDR with someone who's actively using drugs, who is impaired in the session, meaning they come in and they're either they're on an illicit substance of some sort. And we don't want to do EMDR with clients who are recently engaging in self-harm and or actively experiencing suicidal ideations and or have plans or intent. So we're always looking at that as well. I like to look at Safe Complace as it's almost diagnostic. It kind of helps me sometimes understand where the client's at. If they can't get to that Safe Complace, that tells me a lot. That means they may have scored really low on their DES because sometimes clients, they might not understand the question, or maybe they're not being very honest, or maybe they're not very insightful and self-aware, right? That could be another component because these are self-reported. But when I try to get them to their Safe Complace, all of a sudden their body's like, no, last time I did that, I got hurt, right? And their body's not letting them get to Safe Complace. That is an indicator that we need to work through something and do more grounding work. There's also the psychoeducation piece, which I know was talked about as far as trauma-focused CBT. That is an important component in client readiness. See some questions in the chat. Okay, so Matt's asking, would this be contraindicated in outpatient settings, specifically for those who have very recently completed an inpatient program? Do you mean an inpatient program in terms of substance abuse, or like they?
Well, yes, because I'm at Bayview, and so the immediate application I could think of is those who completed treatment for suicidality and substance use disorder issues. Because you mentioned you don't want to use that for people who are either actively using or recently using. So I'm in that terms of scenario, since the inpatient care is relatively a short period, longitudinally speaking. Would this be something contraindicated once they move to an outpatient program? Or is there like a length of time that's preferable between the two?
So it's definitely client specific, Matt, in that case. I think it's like everything else that we do in counseling, there's always decision trees, right? So if the answer to this is yes, then we go here. If the answer to this is no, then we go here. And so it depends. Yes. Oh my goodness. That's like the favorite thing that I hear a lot of in counseling. And it's something that I say all the time to my supervisees. Well, it depends. But it's the truth. I mean, the work that we do is client specific, and it should be. There's no cookie cutter approach. So in those situations, if they're in an intensive outpatient program, some of the things that I would be looking for is, are they actively experiencing suicidal ideation or self-harm? If the answer is no, then that's a good indicator that we can continue moving forward. If they're in a stable environment, meaning they have good emotional supports, there's someone at home that they can rely on, that relational component. Those are things that I'm going to be looking at to determine whether or not they are ready to begin doing EMDR. And when I also talk about readiness, it doesn't mean that we're not doing EMDR work. We're just doing more of the emotional state change exercises. So I always educate my clients on that, like, you're already doing EMDR, because they're like, I want to do EMDR, or oh my goodness, I have adolescents. Sometimes my mom's mad because we didn't do EMDR last week. I'm like, okay, first of all, we did save calm place. But there's this idea that EMDR is only processing and processing trauma, but there's like you just saw, there are phases. And so they would be, to me, they would be in phase 2 of preparation if they're recently out of an IOP program. That's kind of how I would conceptualize it in my brain. And yes, it depends. But that's a good thing. We should always be saying that, I think, for each of our clients. When we start to get into these cookie cutter ideas of people, I think we really leave what it means to be a professional counselor and the way that we help those individual relationships. Okay. Any questions on this? Oh, I put EMDR trained. Why is that there? Make sure that if you get EMDR trained, that you're trained through an EMDRIA approved organization. There are lots of trainings out there like PESI that are not EMDRIA approved, and they're just not going to give you the content that you need to do the work. As you can see today, we've spent almost 2 hours talking about EMDR. And I bet most of you feel like I still don't know what she's saying. I still don't know what EMDR is. Well, yeah, because it's a lot of information. And to be fully trained, you should engage in a 40-hour program. And the very first, it's like 6 days worth of training and then 10 hours of consultation. So it is a lot of information, and you want to make sure that you're being ethical about your practice. So you want to make sure wherever you get trained, that is a reputable, accredited, I use the word accredited because there really is no accrediting body that oversees EMDR that's official, but there is the International Association, which was founded through Shapiro's work, and she's the founder of EMDR. And they really have a lot of gatekeeping practices in place to ensure that the individuals who engage in the training and consulting are well trained enough to do this work ethically. When I first got trained and I went to my first weekend, because it spanned 2 weekends, like a month apart, or 2 months apart, and there was consultation and practice in between. They asked, what was your takeaway? They asked us what our takeaway was. And this is my nerdiness and mama boys comes in, but my takeaway was, with great power comes great responsibility. Who knows where that's from? Somebody, come on. I'm not the only nerd here. Dr. Icon's typing.
That's Spider-Man.
Spider-Man, yes, yes. My now almost 17-year-old son, we still have, I was really grateful. He took it to his dad and I have joint custody. So he took, sorry, you can hear my husband sneezing in the background. I don't know if you can, probably can. So he took his Spider-Man costume for when he was 4 years old, and it had a hole in the center of it. Like, because he wore it that much. He would wear it to the grocery store. He would come up to me and he'd be like, Mom, psst, Mom, psst, and he would like run away or whatever, like he was being taken away. So anyway, I've watched a lot of Spider-Man, all that to say, with great power comes great responsibility. And I think that EMDR is very powerful work, but we have to be ethical and responsible in our utilization of it and make sure that, and I think being trained is a big component of that. So I could talk about Spider-Man stuff for a while. Y'all know my 16-year-old, he's just obsessed. So, okay. So I wanted to talk about what it looks like to be an EMDR therapist specifically, and kind of go into some of those requirements. But before I do that, do y'all want to take a break, or y'all, where are we at as far as, do we need a break? I'm gonna say yes. Let's take a break. Okay, let's come back right at noon. So if you want to, you know what, if you want to grab something to snack on, I'll give you guys about 15 minutes to kind of pull that together, and we'll come back at 12:05 because some of y'all might be hungry. Okay, and you can think of questions too in between. All right. The good news is that we are almost done. So probably won't last all the way till 2 o'clock, maybe 1 o'clock. We'll see. Okay, so hopefully everybody got to grab something or at least kind of stretch. I know I did. I want to kind of come back into what the process is to becoming an EMDR therapist and what that looks like. So the EMDRIA Association, the EMDR International Association, is one of the more popular bodies that serves as an accrediting body for EMDR. Now, like legally speaking, that doesn't mean they own it. I mean, you can go and get EMDR trained wherever you want as an LPC. From an ethical standpoint, from an informed standpoint, I would hope that it would be through an accrediting body. So they do regulate the training process, the certification process, the consultant and training process, and the trainer process. EMDRIA.org is the website, and I can put that in the chat box for you. It's also here, and it has a wide array of resources. It talks about what is EMDR therapy. It's where I pulled several of this information, the information that I presented today from. Give me a second. My daughter's over here distracting me. One second. Sorry about that, y'all. It's mom's already been on the phone for too long in her mind, I'm sure. She's only 7, almost 8. So they are the body that I would trust to approve a training. And so what does it mean to be trained? What does it mean to be certified? So the gold standard to become an EMDR therapist are that you attend a 40-hour program. And this sometimes is all in 1 week. Sometimes it's separated, which I think helps with the practice component into 2 separate trainings. It can be done entirely virtually, and they have in-person options as well. If you go to the EMDRIA website, you'll be able to look up trainings that are upcoming, whether they're virtual or in person, but those are approved trainings. If you just do a Google search, you don't know what you're going to get. So just keeping that in mind as you are thinking about pursuing becoming an EMDR therapist. So once you've completed the training where you've received the information, you've read the EMDR book, you've been able to practice, you've done 10 hours worth of consultations with a consultant or a training supervisor where you're presenting cases. And ultimately what we're looking at is, are you remaining faithful to the model? Are you practicing EMDR as it is said that it needs to be practiced? Does that mean it's the only way to do it? No. Are there adapted protocols? Yes. But just like when you're riding a bike, you got to have the training wheels first before you take those off. So we want you to have the ability to do the protocol. It takes, and it feels very strange, I can tell you, as when I first got trained in 2019, I had already been practicing as a therapist for 6 years. It was like I was in my master's program all over again. That's what it felt like. I had to use a script. I had a supervisor, even though they don't call them supervisors, they call them consultants. It still felt like supervision. And I had to do recordings, and I had to have my recordings evaluated by a consultant and signed off on those. I had to do a certain number of EMDRs sessions in order to qualify, right? So there was a lot that kind of went into that. The recommendation is that when you first begin using EMDR and you're in training and you get trained, is even after that training, you still will likely need to use what's called, I call it the script, which is really just the protocol of what I walked y'all through earlier, where you get the original incident, the image, the negative cog, positive cog, the VOC related to that cognition, the emotions, the subjective unit of disturbance, and the location of the disturbance. You're going to have that all in a script, and you're going to be writing all of that down, and that can serve as your note for the session. It takes most therapists at least 2 years of that being in hand before you can actually move away from it. So the way I just kind of like bounced all those things off, it's because I've been practicing it since 2019. If you would have asked me in 2019, I'd be like, I don't know, let me read what the sheet says. And it feels a little awkward, but it's important that you do that because fidelity to the model is what has shown that is most helpful to our clients. Again, it doesn't mean there aren't adaptive protocols. There's Laura Parnell. She does a lot of tapping. She does a lot of cognitive interweaves. There are different approaches to practicing EMDR. There's now what's called EMDR 2.0. There's an adaptive protocol for working with children and doing it within play therapy. Anna Gomez is a big name on that. So there are different ways to do EMDR, but if you're going to get trained, you need to know the basics before you got to walk before you jump or run, walk before you run. Certified. So certified means you completed a basic training. You've hired a consultant who you're going to do 20 hours worth of consulting. In addition, you have to do a minimum of 50 protocols, meaning 50 EMDR sessions with at least 25 different clients. And you have to do 12 ongoing education units every year. And those have to be EMDRIA approved. So that's to become certified. It can take someone a year. It can take someone 5 years. Everybody is different, depends on the setting, how often you're doing EMDR. It depends too on the financial aspect because you're having to hire a consultant. So, if you can only afford an extra $100 a month, then you're for sure going to be doing at least 20 months because you've got to have 20 hours. And that's if they charge $100. There's some people who don't charge that much. But so just understanding that that is a part of it. The consultation piece for me, I still use it to this day, is so helpful because there is so much complexity in decision trees. I feel like it depends, Matt, comes up a lot. And there's cases where it's like, I don't know what to do next. And that's where someone who's got more experience in practicing EMDR can really be beneficial. I learned more about, in the certification process, I learned more about treating complex PTSD and using additional resources and tools that would allow me to kind of help my clients deal with high DES scores. I felt more comfortable, I would say, and more confident than I did before. So. Okay. Does anybody have any questions about being trained versus certified? If you go to the link, you'll find out more information there.
Okay. So, with that being said, as long as it's here on site, when I come in at 9 in the morning, the keys are already in that job slot. I'm gonna.
I thought it sounded like a serious question. Lena, your mute button went off, I think, on accident. Okay. Does anybody have any additional questions about becoming trained versus certified, or any thoughts on moving forward? Okay. I hope that you all decide to learn to do EMDR, and at some point you identify this as a box that you want to check. I think it's a great tool to integrate into practice. Again, as I've said before, it's not the only way, but it's very useful, especially if you're working with clients who have significant trauma or complex trauma. And I just wanted to highlight this quote: "No one is useless in this world who lightens the burdens of another." So I really feel that speaks to the work that we do as counselors, whether we're doing EMDR or not. And that's heavy work, which brings me into demonstrating the light stream today. I would like an opportunity to be able to engage each of you if you're up for it. I'm going to stop sharing. And You can keep your camera on if you choose, or you can turn your camera off if that's more comfortable for you. You can close your eyes or lower your gaze, whatever works best as we go through this. I'm going to pull up the light stream activity, so just give me a second. I should have already had this out, but I didn't. I just want everybody to take a deep breath. Just kind of notice the space you're in. Kind of grounding yourself into your chair. And I want you to bring up a disturbing target. Maybe it's that you had to be here all day. It's on a Saturday. Maybe that's a disturbance. Maybe it's reading about Darius's experiences. Maybe it's the nerves of being a counselor and the weight of what we do. Whatever that disturbance is, I want you to notice it and concentrate on the body sensation that comes up with that disturbance. I want you to bring that to mind. And remembering as we go through this process, this is an imaginal exercise and there are no right or wrong answers. And as you answer these questions, you can answer them in your head. You don't have to do it out loud, but you can if you wish, just keep you on mute. Concentrating on that feeling in your body. If that feeling were to have a shape, what would it be? Would it be round, square, triangle? Whatever it is, just notice that feeling turning into that shape. And if it had a size, what size would it be? Would it be large, small, medium, microscopic, or as big as the universe? Then I want you to give it a color. Now it has size, shape, so give it a color. Taking in a deep breath, noticing your surroundings. Now I want you to identify if it had texture, what would it feel like? So holding it in your hands, imagining yourself holding it. What does it feel like to your fingertips? And if it made a sound, would it be high-pitched or low? And don't try to focus too much on what it would sound like, just if it would be a high-pitched or low-pitched sound. Now that you've identified the size, shape, color, temperature, texture, and sound, I want you to notice and think about and visualize which of your favorite colors you would associate with the power of healing. We're taking in a deep breath in through the nose. Exhaling. I want you to imagine this favorite colored light coming in through the top of your head and directing itself at that shape in your body. Let's pretend that the source of this light is like the cosmos. The more you see, the more you have available. The light directs itself at that shape, penetrates it, resonates and vibrates in and around it. This light is melting over the shape. As it is doing so, continuing to allow the same light to direct itself to that area and simultaneously allow it to come in and gently and easily fill your entire head, easily and gently. Then allow it to descend through your neck, into your shoulders, down your arms, into your hands, and out of your fingertips. Then allow it to come down your neck, into the trunk of your body, easily and gently. And allow it to descend through your bottom, into your legs, streaming down your legs, and flowing out of your feet. Remembering your breath, taking in a deep breath and releasing that disturbing target. This light represents your ability to find peace and calm. You hold this power within you. Go ahead and take a deep breath in. And whenever you're ready, returning to our time together, turning your screens back on, opening your eyes. Would anybody like to share what that was like for them? Kind of talk through that? Is it easy, difficult? Did it work? Did it not work?
I guess I'll kind of talk through it. I left my camera on so that you had someone to talk to. So I was like giving you.
Thank you.
Yeah. But yeah, I think for me, I guess starting with the disturbance, for me, it was like thinking about all the things that I needed to do today. And I was noticing like tension in my chest. And so whenever we went into like thinking about a shape, for me, I was thinking of like a square, and the box and the edges were really sharp, and it was like pushing on the inside of my chest, and then it was just solid black and very metallic and cold. And then spirituality and religion is a big part of me. So when we were thinking about the light, I was really looking at that through my lens of what that would be. It was certainly like very powerful to kind of ground myself in what I believe in and let that change the way that I was experiencing like those heavy feelings. And you did it very well also. So that was also helpful that you like knew what you were doing. But yeah, it was a super positive experience.
I was literally reading from a script, so. And I do read from it whenever I do it with my clients too.
Well, that's
but yes, and I've gotten used to using it. I use it a lot with clients. It's one of my favorite activities to do. It's a little bit more engaging when you're on a one-on-one. So like the way I illustrated it today was like in a group, but when you're with a client, they verbalize to you the shape, the color, the size, and then you check in and make sure, is something happening to the shape, or is the light blocking, or is the light, because sometimes that's hard for the client. And so you kind of visit that with them and work through that if it comes up. But that was really neat to hear your experience, Jolie, and then your the way that you shared that you brought in your spirituality aspect to it. Like that's one of the things I love about EMDR is the creativity. And when you're practicing EMDR, you also learn a lot about resourcing with clients and bringing in natural resources into the work that you do with them. But sometimes what happens is there's spontaneous resourcing. And all of a sudden in the middle of an EMDR session, the client will be like, I see my adult self I see my child self, or I want to go and pick her up. I want to go and pick up that child and hug her. Go with that, do that. And that's their resourcing, or their spirituality comes in. That's their natural resourcing. And some clients will develop that together, and others, it just is very spontaneous. You trying to unmute? Do you have a question? It just says iPhone. Okay, I don't know what your name is. Does anybody else want to share about what that was like? If it wasn't effective, that's okay. Hopefully each of you have your own counselor that you bounce stuff off of and work through, and the work you do, it's, you know, you become counselors in the future. And if anything disturbing came up or too overwhelming came up today, that you work through that with your own counselor. I know that's been one of the most important things that I could do as a counselor, is to have my own person who can help me through challenging times.
So Natalie shared in the chat that she could see how this would require a lot of training, because it's kind of a delicate process sometimes. And then she also felt that it was very enjoyable. And I'm kind of similar to Matt. He shared that guided meditation and reflections and mindfulness type activities can be difficult for some people. Either just that's just not your feel for things, or maybe you just get distracted very easily. But certainly he can see the value in that. And I think for me, the value in recognizing, like just taking a minute to recognize, like, oh, okay, I've got this stuff going on, the deep breathing and stuff like that, it doesn't really help me. It doesn't really resolve like the discomfort that I feel, but it is usually really helpful for helping me realize, like, oh shoot, I need to take a hot minute and like address this in my own way, whatever that looks like.
Absolutely. I think, so I just saw in the chat box those two comments, and, you know, from a perspective, from an EMDR framework, right, what we're constantly looking at is the client's ability to emotionally regulate and the decrease in their symptoms, whether that be anxiety or symptoms of traumatic stress. And when we do these activities, sometimes we find that they can't do them. And that's okay. There's nothing wrong with that, but it helps us understand, okay, we need to continue doing more grounding work. And interpret that book into the pocket guide that you can put in your pocket, but you really can't. Interpersonal neurobiology, what it's showing is the mind and the brain and the body, the ability to relax is such an important component, because that facilitates sleep. My dog, yeah. That facilitates the ability to sleep, to rest, to give our minds a break from the constant go, 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 go. If we don't do that, then we're not functioning at the best of our ability. And that's okay. There's nothing wrong with that. But as a therapist, being mindful of what you do in your own time, are you able to achieve what you're working with your clients to achieve? And mindfulness is linked to, like I said, better sleep, enhanced learning, being able to manage stressors more effectively. So being able to achieve that is so important, especially as we look at neuroplasticity, Nat, like you mentioned, and being able to heal from trauma. So if today was, you know, if that activity was challenging, then noticing that and saying, okay, what do I need to do moving forward? Do I need to do some more yoga work? I think yoga is important for everybody. My daughter is playing with the dog, and she's telling the dog to be quiet, even though she's the one who's instigating this. It's like, makes no sense to me, but we'll talk about this after. So, okay, any other questions about either the light stream? Like I said, that would be one-on-one. You would go through with the client. It typically takes a little longer than it took today, because I ran through it rather than having that collaborative approach that I would do in a one-on-one. Any other thoughts? Make sure there's not something in the chat box. Natalie says, I can see how it would require a lot of training. Yes, absolutely. And I still feel like I'm learning. I mean, I'm only 3 years into doing EMDR work. And I'm still learning every day. My clients teach me things. It came from Compassion Works. It is, I can put it in, there you go. Thank you, Jolie. I was saying I could put it into the chat box, but Jolie did that for me. Sorry. Okay, the puppy thinks she's having a good time. She's playing. She has no clue what's going on. And then, okay, so let's see, references. So I'm going to put these two in the chat box. Well, I've already done the mdria.org, but this is the, I don't know how to get it into the chat box. Well, I think if you just, has anybody been, I can't log in or I can't do anything when my screen is like this. Ashley, do you mind like just putting this like in Amazon? I'm not saying you have to buy it from Amazon, but so you can see what the book is. You might have access to it through your university. Might be able to get a free copy of it, but at least so you can know what book I'm referencing. And this was written by the founder, Francine Shapiro. And hold on, give me a second, I'm gonna get my dog. It was written by Francine Shapiro, and it really outlines, I think, some of the basic principles and guiding tools that you need to being able to do EMDR. Everything, I like to say, everything is in there. Of course, there is stuff that we're discovering kind of every day as we continue down the field of neuroscience and understanding the neurobiology that we're still really discovering, I think, as we continue to do the work we do. Does anybody have any additional questions?
So Janelle, do you happen to know of a resource or a place maybe where our students can see like a recorded example session of what EMDR might look like?
I don't, I mean, I don't know if MDR website has one. I know that they'll typically do them when you're in trainings, they'll do demos. I could do a demo today. If somebody wanted to volunteer, I wouldn't mind doing one. I totally understand if you don't. I mean, it would have to be on something that's like a low level disturbance. There is a possibility that it could bring up more stuff. And so I would just ask that, you connect with me after the training if you need to, and that you have somebody that you can connect with. So I could do a demonstration if you wanted. We have time for it. Otherwise, I don't know of anywhere. I've never seen just like on the web that was reputable, unless you go into an EMDR training or you witness one. I had a student sit in on a session recently. One of my student supervisors got to sit in on an EMDR session.
Gotcha. Yeah, I also had the opportunity to sit in on someone who was trained when I was in my practicum experience, and I think that that's very helpful. But just for the sake of keeping everyone safe today, we probably should not do a demonstration.
Yes. We do them in the trainings. So we do demos with trainees, but there's typically like it's done on something very small and minor. And most often people will find it very helpful, but it does require a certain level of vulnerability. And so there are risk factors, of course. But I mean, other than, like I said, other than going in and seeing it when you're doing a training or you practice it, I don't. In the book, it actually like scripts out sessions. So like it'll like have like work like a transcript from an EMDR session. Let's see something. Oh, there's the book. Yes. I mean, and you're welcome to Google. I just don't know of any reputable sources that keep them on their website. I know that people will do demos in trainings, whether they do like a live demo so you can see it in action, or they have a pre-recorded one. And I toyed around with the idea of bringing one in, but confidentiality wise, I wouldn't be able to do that. I would have had to like practiced with someone and then put that as my demo, but I wouldn't have been able to do it with like any of my existing clients because even if they would have done a release form, it wouldn't have been appropriate. So I just didn't want to. I did a few EMDR sessions this week. I'm always like, what? I tell my husband, I'm going to do some EMDR on that. I'm just kidding with him. But it's a wonderful tool. Like I really enjoyed the practice and the work of it. Like I said, when I first got trained, I thought, where has this been all my career? Okay, I'm going to stop my sharing and go back to the gallery so I can see everybody. Any other questions, thoughts? I know we're finishing kind of early, but I feel like we got through most of the material. How many of you are going to do EMDR? Get EMDR trained? Jolie's like, I am, I'm convinced. If you are at the student level, yay, Dr. Icon. If you are at the student level, it is less expensive. If you're at the associate level, it is also less expensive. So I always encourage my associates like, hey, get EMDR trained. We have a scholarship in my practice where we award one associate level counselor the ability to become EMDR trained. And we pay for it and they can work towards their certification process. That's in my own practice. But it is a little bit less expensive than if you were to be fully licensed. And then you get, if you have a supervisor who is EMDR trained, at least minimum, then you can have both of that kind of component while you're practicing. So I do my, I work with or like contract with a company called Compassion Works. And Jordan, the owner of that organization, was trained by Francine Shapiro. And so it's, so to see their training materials, oh my goodness, it's very in-depth. They do virtual. Of course, that's my little plug for Compassion Works, right? But go to the website, andrea.org, and you can find a list of people who are accredited. I just would ask that you do it through somewhere accredited because you just don't know what you're going to get if it doesn't have, if it's not following through with the guidelines.
All right. Well, thank you, Janelle, for that lovely kind of introductory presentation on EMDR. I think that was extremely helpful because a lot of times there's a lot of misconceptions about EMDR and what it is and whether, just regular therapists can do it, who needs to be trained, how certification works, all of that good stuff. So again, we thank you. For our TexCHIPers, we're gonna stay back for a minute. We've got some stuff to touch base on, but again, we want to say thank you, Janelle, and we hope that you have a great rest of your day.
Thank you so much.
We'll be kind of keeping in touch with you.
Yes, absolutely. Talk to y'all soon. Bye. Have a good day.
Thank you. Bye. You too.
My dog said bye also. I heard her. All right. Bye.